Arun, you have any presentation to be done today?
I don't have any.
Okay.
I have. I'm a
Dr. Saudullah,
Yes, sir.
it's sharp 5. With the permission of Dr. Shiv Nair, we can start. Only one more person is yet to join. That's Dr. Rajiv. He'll join in another 2 minutes.
Yeah. So, can I go ahead?
Yes, I'm ready.
Oh, okay, Dr. Stenayas. All right, welcome to everyone. I think this is a very important session, collaborative partnership in healthcare delivery, and between the government and the private sector, and between private sector partners, many collaborations are possible. And in fact, I was reading an article, KPMG survey from Ireland just a couple of days ago, interviewing 100 CEOs and their views about healthcare. So I think you've got a very good high-powered, panel. Rajiv Jayadevan, Arjun Kumar, and Atul Mohan Pachar. And welcome to everyone. My job is to just introduce Dr. Shiva S.K. Nair, that will be well known. And Dr. S.K. Nair is the head of the Department of Cardiac Surgery and the medical director of Rajgiri Hospital, and is a well-known cardiothoracic surgeon, and thousands of surgeries to his credit, and 32 years of experience, and also an alumni of the Harvard Medical School, and had 45 publications. And I think S.K. Nair is moderating the session, and welcome to you, Dr. S.K. Nair. Over to you. Thank you.
Welcome to the ninth edition of the Kerala Health Tourism 2020, organized by the Confederation of Indian Industry as a virtual conference. I would like to thank the CII, its president, Mr. John Muthoot, convener of the healthcare panel, Dr. Sahadullah, and Mr. Deepu Thomas. Today is the fourth session of this virtual meeting with a focus on healthcare in the future, its revival and sustainability in these very turbulent times. We have today with us a panel of great eminence who will take us through these sessions with 4 presentations with a focus on policy, quality, sustainability, and patient safety issues. Each presentation will be for about 15 minutes, and we hope our panelists will be able to take some questions at the end of the session. Our first speaker is Dr. Rajiv Jayadevan, and it gives me great pleasure to introduce him as the immediate past president of the Cochin chapter of the IMA. Dr. Jayadevan is a medical gastroenterologist, a public educator on health and social issues, a researcher, an author on a wide variety of health matters, an invited speaker on a number of TV and radio programs. His Twitter feed and thoughtful analytical articles on complex health topics are widely read, and he has just released a book, Think Like a Doctor. Dr. Jayadevan has a brilliant academic record throughout his career, being a rank holder in school examinations, the medical entrance exam, and a gold medalist during his undergraduate and postgraduate studies in medicine at the Christian Medical College in Vellore. Dr. Jayadevan will be speaking to us about scientific facts on COVID-19 and how they will help shape our policies in reference to health tourism. Dr. Jayadevan, please. Unmute.
Thank you very much for the generous introduction. My name is Rajiv Jayadevan. I'm a medical gastroenterologist. I'm also an IMA, Indian Medical Association office bearer, and I will be speaking about the health and the science aspects of COVID-19 and how it could shape our policy decisions in the topic of interest. I will be speaking for 15 minutes, so I will go straight to the talk. COVID-19 is familiar to all of us. No introduction is necessary for that. I'll say a few important points about COVID-19 as somebody who's really chased this virus ever since it started in China. The first thing I would like to say is that science is inconvenient. Science is nothing but the truth, and sometimes truth is really not what we want to hear. But therein lies the problem, because people like to hear what they want to hear and they like to read what they want to read. And sometimes truth takes a backseat. Yesterday, the WHO came out with the solidarity trial results that basically said whatever we had been doing so far has been wrong. I'm talking about specific medicines that had been used for this particular virus. So this is a bit of information that we need to take in. We need to be impassionate about science. We need to just take in what science says. The second important development that happened in COVID-19 is perhaps the most disappointing development that has occurred is that reinfections are a reality. I had written quite a bit about the possibility of reinfection, and now they have occurred. And basically, it means that if you have had COVID once, there is no guarantee that you will not get it again. And that is a very important piece of information that will change our policies and the way we see the future. We do not know how frequently they happen. We do not know how severe they might be, even though the earliest analysis of 23 cases published show that at least a half of them were more severe than the first. Again, it is not good news, which is why I said statement number one is truth is never convenient. So those are the two significant developments that have happened. And with that, I will go on to what we need to know about the spread of the disease, and then we will come to what we can do in this panel. All viruses have their own personalities. They are all animals. It's like an elephant is different from a leopard, and a leopard is different from a dog, and a dog is different from a tortoise. Likewise, the new coronavirus has certain traits that are being studied and understood. And it is not fair to generalize viruses into one box. Human beings have a tendency to put everything into boxes, and people who know science will advise against it. No, this virus is not to be kept in a box. This virus spreads between people, and just like the dengue virus uses a mosquito to travel between two people, this virus uses a droplet to travel between two people. Now, what is a droplet? I'm speaking now, and my vocal cords are vibrating continuously as I speak. And as they vibrate, a thin film of mucus is exploding between my vocal cords, and this film is being pushed out as an invisible mist in the room that I'm sitting in. Nobody can see it, but these droplets are less than 5 micrometers in size. A micrometer is 1,000th of a millimeter. The reason I mentioned the size is because when you imagine a droplet of rain, it falls onto the ground. Why? Because of gravity. When the droplet size falls below 5 microns, it becomes immune to gravity. It stays afloat in the air and circulates in the room for hours together. And the landmark paper by Dormalin from New England Journal of Medicine, which most of you have read from April, has shown that the virus will remain alive for several hours in an aerosol. Now, let's put that in context. Imagine that we are sitting in a room, instead of having a Zoom meeting or a video meeting, imagine that we were all sitting in a room and I am talking. And God forbid, if I had the virus, in about an hour, everybody will be infected in the room. It does not matter. Everybody is guaranteed to be infected. Now, that is called a super spreading event. Now, super spreading event can happen in a small room or in a large theater. So, which is why doctors who know about this, who have good knowledge about this, would always say, never have a meeting in a closed room and always keep those doors and windows open. Now, those are two key factors. In fact, if you follow the work in Germany, that in fact, I believe that they are one of the world's best when it came to getting a handle on the pandemic for many reasons. We don't have the time to discuss the reasons here. But let's trust what Germany does. They are now actively advocating a simple measure. They're not talking about monoclonal antibodies. They're talking about, can you keep that window open? That is the message that came out over the last several days from Germany. Please keep the windows open. So I just want to say that fancy treatments, just like chloroquine and medicines, pills, are not the answer. Simple, science-based, physics-based measures are the answer. Ventilation is the key. If there is one message I would like to give out from my talk about COVID-19 and its science, there's nothing fancy about it, but just leave the windows open and reduce the conversation between people. The more people talk, the more the droplets are and the longer they stay in the air. In fact, we just submitted a paper tonight about why in Kerala we are having a surge. It's a hypothesis. This is not a fact. It's a hypothesis. Our relative humidity is about 93%. Karachi is having 19% or 20%. When we have a high relative humidity, it means that these droplets are not going to evaporate. Remember, a droplet is a blob of fluid, the surface of which is held tightly with an inward force, which is called surface tension. As the droplet evaporates, the droplet gets smaller and smaller. At some point, the surface stability is lost and it explodes and it vanishes. When there's a lot of humidity, droplets don't explode. They last longer in the air and they travel further, carrying the virus to more people than it would in less humid conditions. Unfortunately, Kerala is in a very humid situation right now, and that is one of the reasons, in addition to our crowd behavior, that the virus is spreading rapidly. Now, these are snippets of science that we can use in policy decisions. As far as the medical tourism angle goes, we call it MVT or medical value tourism. People come to Kerala or India for medical tourism mainly for three reasons. One is they come because they want to have a surgery done here at a lower cost than they would elsewhere. Second is they may want to get a second opinion or a good consultation with a doctor who is of good repute. And the third is they want to cultivate wellness. Now that is, I believe, the mainstay of medical tourism, because people really want to feel well. They want to look after their body, prevent disease, get healthier, get good nutrition, get good advice, and so on. And then a little bit of rehabilitation for people who have chronic illnesses, for which modern medicine has very little to offer. Now, with that angle, I will say COVID-19 opens up a vast new possibility here. It is called the post-COVID. As most of us know here, post-COVID is a syndrome where many people who had this virus develop diffuse symptoms of fatigue, malaise, weakness, limb weakness, depression-like symptoms, a little bit of memory loss, swelling of the feet. Now, these are symptoms, and many of them also get some pulmonary fibrosis, which basically means scar tissue developing in the lungs, which reduces their exercise capacity. Now, these are new diseases, the treatment of which is not known, and the course is still yet to be defined. But this is not going to go away for a long time. Post-COVID is here to stay, just like COVID is here to stay. And there will be a lot of patients all over the world who want to preserve their wellness or at least work their way back to reasonably good health so that they can lead a productive life. And there comes India. We have the best rejuvenating mechanisms that are that date back to the to the ancient ages, and that is an area that we need to work on. We need to get all the data together, see if we can come up with a protocol to treat these people. So that's one. And as far as the COVID situation goes, the second problem I would like to address here is the safety of our guests from outside countries. There may be Indians who want to pursue their treatment in their home country, or there may be people who are not of Indian origin who want to come back to India. Now, we need to take care of our host. The safety of our host is paramount. Just like I was the president of the Indian Medical Association Cochin chapter, my biggest priority was the safety of the doctors, number one. I needed to prevent them from dying. So that was one of the areas I worked the hardest on. The same way, when we as a host take care of these guests, we need to make sure that they are safe. And how do we do that? For one, we need to make sure that they don't catch an infection here. So we need to make sure that whatever channels we put them through, we did not give them an infection they did not have before. Our hospitals and our healthcare establishments and our rehabilitation centers, they're all clean and they follow protocol. But with COVID comes a new level of management and a new level of control, which we need to achieve. And that we need to put our heads together for that. And the third is when they travel, there will be some logistical issues. See, as of now, all countries all over the world, they have a quarantine period ranging from 7 days to 14 days. Anyone who enters any country will have to spend about 14 days in quarantine. Now, for someone that's hard pressed for time, that will be logistically difficult. But India has an answer for that as well. They could possibly, if they're coming in for a wellness visit, they could possibly get the wellness treatment started with proper protocol and preventive strategies in place, get their testing done, get their quarantine over with, and then ease into other modes of treatment. Obviously, this will not work for somebody who wants a hernia operation tomorrow. So for those individuals, we will really have to follow a lot of protocol. The fifth is essentially when they travel. We do not want them to be infected on a flight. So there lies the question, how safe are these flights? I'll say this, with all the available scientific evidence, flights are one of the safest places you can be in, provided, one, everyone wears a mask, and B, the aircraft carrier complies with the regulation of replacement of air X number of times every hour. So there is the cabin air gets replaced through HEPA filters. So which is why even if there is a patient with COVID-19 on the aircraft, the air gets replaced. So you are less likely to get infected on a flight than on an air-conditioned bus that you might be traveling in. There are plenty of reports of infection on buses, especially from China, air-conditioned buses in China. But even on an 11-hour flight, there has been encouraging reports about how safe these flights can be. And flights from the Middle East, from where many patients come to Kerala or India are, the flights are no longer than 3 or 4 hours. So it doesn't pose that much of a risk. More of the risk happens when you come out of the flight and when you travel and so on. So obviously, we have to make sure that they travel to their destination, their destinations, the mode of treatments or the mode of facilities we provide in the destinations are COVID safe. That brings us to the topic of what is called a COVID protocol. You know, wherever you go, you hear the magic word COVID protocol. But you know what? Do we really have a COVID protocol? We need to ask ourselves that. I believe not. We don't have a COVID protocol. One man's COVID protocol is not the same as another person's. One shop may have one protocol, another establishment may have another. We can't do that. We need to sit together with experts within the government and come up with protocols for small stores, for supermarkets, for restaurants, for hospitals, for clinics, everything under one umbrella, for events, for safe conducting of events, and so on. And these protocols, I suggest that they can be labeled protocol 1.0, 2.0, and 3.0 because science is ever changing. We are going to have different protocols as evidence comes and new situations arise. COVID-19 pandemic is not going away for the foreseeable future, and science will continue to change. But we need to work now. I looked at the Kerala Tourism website yesterday just to see where we were. I was disappointed to see that there was no mention about COVID-19 at all, and there was no mention about travel. There was no FAQs about is it safe to travel to India. So we need to urgently upgrade our website, and once these protocols are in place, we need to put them in place. We need to be prepared for changes, and we can't be dogmatic about what we want to say. All right. So I believe that my 15 minutes are up, and I will stop now. There's plenty to discuss, but there are some limitations for a time slot of 15 minutes. I hope the scientific information was helpful, and it will help us make decisions. Thank you.
Thank you, Dr. Jayadevan, for a wonderful presentation and presenting some very pertinent scientific facts. We'll get back to you at the end of the session. Can I now invite our next speaker, Dr. Atul Mohan Kochar. He is the Chief Executive Officer, National Accreditation Board for Hospitals and Healthcare Providers of India, an organization which leads us in establishing standards for quality and patient care and patient safety in healthcare. Dr. Kochar is a professor of dermatology at the Maulana Azad Medical College and the Lok Nayak Hospital in New Delhi. He was a recipient of the University Gold Medal as a postgraduate student and has been an office bearer of the Delhi chapter of the Indian Association of Dermatology, Venereology and Leprology. We are very grateful that he accepted our invitation to speak at this meeting. And I think there is no better person than him to speak on quality issues in these very difficult times. Dr. Kochar.
Thank you so much, sir. So thank you, Dr. Shadullah, sir. Thank you, CII. And thank you, Dr. Rajiv, for such a wonderful opening. I mean, this has been a real learning, actually very practical, very succinct and liberally peppered with your wonderful vocabulary. I mean, it was a pleasure to listen to you. So thank you so much. I'll attempt to cover the 15 minutes, though I'm not very certain I'll be able to do that. But talking about quality beyond accreditation, please allow me to submit the NABH perspective, where we were, where we are, and where we aspire to be post-COVID. I'm sure most of us are already aware about the NABH, the National Accreditation Board for Hospitals and Healthcare Providers. This is a constituent board of Quality Council of India. Quality Council of India is an autonomous body under the Ministry of Commerce, DPIIT. It's kind of a public-people partnership which was founded in 1997, the Quality Council of India. And then it went on to develop 5 boards. One board is NABH, which came about in 2006 with active partnership of Ministry of Health and Family Welfare, industry bodies like FICCI, ASSOCHAM, and CII, of course. And then we have NABL, which is our sister board. We have education and training board called NABET. Then a certification bodies board called NABCB. And we have one promotional board called NBQP, National Board for Quality Promotion. We have a whole lot of divisions which take care of very critical government work, and about 750 people in total working from Delhi and around. There are many active, successful projects like with Coal India, Kaya Kalp, so many other factors which are there. Talking about the programs, since 2005, we are running about 21 programs under the 3 broad headings of accreditation, certification, and empanelment. Our hospital accreditation program is benchmarked against ISQA. We as an organization are also benchmarked against ISQA. So though we are a 15-year young association compared to JCI, which is nearly 70 years old, our standards are globally benchmarked. And currently, across programs, including the very famous Ayush, which we have developed along with the Ministry of Ayush, we have total partnership with about 9,600 hospitals and counting. So this is what we were doing. We have a set processes for accreditation program, certification program, empanelment program launched about 6 years back. We moved on from an old portal to a very objective app-based platform for smaller hospitals called the HOPE, Hospital Online Platform for Entry-Level Certification. So that caught on, and currently there are nearly 6,000 hospitals which have started their quality journey, which is kind of a stepping stone towards full accreditation. Then there are specialty programs like blood bank, medical imaging, emergency certification, even Panchkarma clinics, ethical committee, allopathy clinics. So most of the clinicians, which I was also a few years back, are wary of these things as regulatory nuances or nuisances rather. So, but please believe me that quality is the only way forward. And how so? Please allow me to submit. And what Dr. Rajiv just now elaborated beautifully about the COVID and the post-COVID and the uncertainties. I'll only submit that quality has been a great enabler in the handling of this disaster. The current global pandemic has, if anything, as a silver lining, forced us to introspect, forced us to adapt and to adopt various things. We all realize and we know now that there was a changing guidance actually. We have realized the significance of innate immunity, the value of good health, uh, free from comorbidity, and the importance of balance in all spheres of life. It has also unhesitatingly taught us that quality and accreditation has been a great enabler in empowering the healthcare organizations, whether big or small, in managing this unprecedented disaster. So any hospital, partnering with NABH under any program across whether Ayush or anything or any other accreditation body has fared better. And this, I'm sure, data will show in future. We are collating that because they were all used to following SOPs. They were all used to carrying out mock drills, and they very beautifully adapted. So they all got together, they adapted, and then came together to minimize the morbidity and the mortalities. So there are some lessons from the pandemic for all of this. But just to give a line about where we were, we all know that the earlier methodology of assessment was we have a wonderful team of assessors, which are the backbone of any accreditation body. They move about in spaces, they travel across geographies, and then they submit their report, they assess and submit their report. So which goes to a third party accreditation body. So we all were used to this physical movements and crisscrossing which was happening. So COVID threw this, threw all of us off target and off our lines for a month or so. Then we adapted and started adapting. We tried to get our act together. We drafted and redrafted policies, and we are still modifying. And finally, we adapted to this remote assessment process. So remote assessment is one area where we are now continuing. And what are the lessons from this COVID pandemic for all of us, which are there? So please allow me to submit. I mean, I'm not saying the pandemic is over now. It's still very much on, as Dr. Rajiv said, and there are so many post-COVID aspects which are still in the gray zone. Not one shade, not 50 shades, but a million shades of gray are there. But what all this pandemic and what are the messages for the quality and accreditation body like NABH and for all of us maybe? So I'll be speaking as Jampur, so I'm not sure whether I'll be coherent most of the time, but please bear with me. So one thing which is a great fallout of this pandemic is that we've all learned to share our resources, collate everything, share resources as a global body, because the changing dynamic, I know of a US physician group on the Facebook. I mean, we logged in and then within days it swelled to 1 lakh physicians, I mean, across world actually. And then within months it's crossed 2 lakhs, and there were and counting, and there were real-time question exchange. So that is the only way forward. I mean, the pandemic has revealed the importance of sharing resources and knowledge. The world has joined hands in an unparalleled attempt to limit misery. Dynamic and prompt sharing of PPEs. I mean, NABH was the first organization, I can very proudly say so, to partner with CII to create a virtual marketplace, to partner with FICCI, let's say, to create a data bank of our capacity to enhance the critical beds. So all of us got together. We did 8 programs, webinars with CII for capacity building to train our health workers into ventilator monitoring, which were very successful. So we had very limited role to play in this, but the point is that all of us got together uh, to behave as one and to extend our uh, talents and our capacities. We launched a Quality Connect initiative, which became very popular, and this is the only way forward. And from 15th of August this year, we decided that all our standards, in the spirit of the freedom, in the Quality Connect spirit, will be free. So I'll encourage all of you to log on to our website, www.nabh.co, and download the standards, all the clinicians who are there, especially because I still feel that clinicians need to take a stellar role. I mean, quality department, many distinguished clinicians are part of our assessor team and our board also, and they give us continuing guidance. But till the time the people who drive the hospitals, the clinicians, the on-ground consultants and specialists and doctors and nursing officers, they take interest. So please download our standards across domains and go through them. So that will be one big step, and all of them are free since August. The second, sharing of resources is one big message, which is the only way forward. Traditional knowledge and wisdom came up like anything. I mean, it was already there. I mean, it's Ayurveda and other disciplines of Ayush have already been there in our country, especially in the Kerala sector. And you notice that there's a whole lot of people who come and take benefit. But now we need to validate these wisdoms, just make them popular as modern medicine. It was very difficult for me to understand coming from a traditional modern medicine background and dermatology, but uh, I've realized that there's so much goodness in it. We only need to give it a structure. We need to put in more RCTs, more meta-analysis, validate these treatments in a spirit of openness, because most of them have been founded and are continue to be built upon a foundation of tradition. So we need to put in more scientific in their own form, the pyramid evidence, the evidence pyramid, and move beyond expert knowledge and go on to RCTs and conduct more studies and give this wonderful traditional knowledge a proper footing, and take it across world. Uh, in that spirit, NABH, as part of the future initiative, is launching by the end of this month the entry-level Ayush program, which is meant to target smaller setups of Ayush. In fact, Government of India has mandated that we need to certify 12,500 entry-level centers, very small, less than no beds, less than 1 to 5 beds. So this is going to popularize. So that's a commitment which we are willing to take. Uh, One point here is that there has been a clarion call by Honorable PMO also, which CII has beautifully endorsed, about the Atmanirbhar Bharat, the self-reliant India. So I'm very proud to submit that all our standards, though they are benchmarked against the best in the world, are Atmanirbhar. They are homegrown standards. They are very much in sync with the realities of Indian healthcare. So without diluting or compromising on anything, we are trying to build a culture of quality which is very, very founded in the Indianness. Uh, Third point which came about is that on 25th of March, the Board of Governors in super session of the MCI, they gave us a silver lining gift, if we can say that, of legalizing the telehealth or the telemedicine guidelines. They're very, very uh, sketchy at the moment, but at least something is there. Prior to that, it was illegal. I mean, I'm sure IMA also raised cudgel about that, but the COVID and the pandemic brought into focus the need for a small sector of such thing. I mean, there's no substitute for empathy, no substitute for the touch of a clinician. But I think telemedicine is here to stay. And going forward, as we realize in some of the wonderful hospitals of Kerala, which I'm familiar with, they're already moved on to tele ICUs also. So the digital health is coming up in a big way. And that also throws us the challenges of information, data collection, capturing who's the owner of the data, the privacy, security, interoperability. So all those factors suddenly are brought into focus. So we are drafting those standards. There are already tech standards available. There is so much already available. We just want to make and ensure that we are in sync with the self-reliant India. We don't want too much dependence on ISO or other thing. We want to concentrate on open source standards like FHIR. So this is our initiative, and we are trying to work on that, because M-Health, Connected Health, EICU, they are all likely to stay here. One major thing about quality and accreditation is that accreditation is meant to be the baseline performance yardstick. Uh, there are many hospitals, rather most hospitals in Kerala and many other metro cities are way beyond that basis of baseline of accreditation. They've proceeded towards excellence. But this pandemic has taught us that we cannot limit ourselves into creating these islands of excellence. If we are to move beyond quality, move beyond accreditation, then we have to reach out and connect to people. So that's a basic, very important lesson for all of us, that we must reach out to tier 2, tier 3, tier 6 cities across our big country. We must reach out there. We must connect to people, tell them about the essentials of patient safety goals. What is the importance of hand hygiene? What is the importance of good communication? What is the importance of surgical safety checklist? So reaching much beyond there and talk to the basics about people. So unless our policies are drafted for those people, so we must be committed, and we are committed to taking those quality measures to the last man in the line. The self-development goals of 2030. So basic criterias now need to reach out to people in the last line. So that's a very, very big lesson for all of us. And this is where NABH is aspiring to be in the coming few months, and or the virtual assessments will continue because they offer us a low cost way. I mean, I'm very fortunate that I'm talking to such great people sitting here in Delhi and not having to travel there. So while the traditional methods and traditional wisdom of modern medicine or Ayush will continue, but the more important to reach out to the people who have currently no access. I mean, there are more than 1 lakh hospitals, and even our Rohini portal of IRDA has a registration of about 20,000 small hospitals, for which out about 6,000 we have managed to reach, about 1,000 are pending. So to cover. So that's where the role of CII and all these associations, wonderful associations, come in, where we can help reach out to people, educate them about the essentials of donning, doffing of PPE, if not PPE, the hand hygiene, the surgical safety checklist, all patient safety goals. So that's a very small submission from NABH. So NABH is committed to taking quality to the last man in the line. And time has come for us to, while we are aspiring for the moon also, to reach out to the opposite, to the furthest corners of the country, and create a culture and an ecosystem of quality. So thank you, sir, for this opportunity. Thank you once again.
Thank you, Dr. Kochhar. That was a really excellent presentation regarding quality standards being put forward by NABH, and of course the collaboration, the sharing of information and all, which has become so much more important in these very terrible times. Thank you very much. We'll come back to you with some questions at the end of the session. Now it gives me really great pleasure to introduce the third speaker of today. That's Mr. Arun Kumar, the Chairman and CEO of KPMG India. Mr. Arun Kumar is truly an accomplished global citizen with a stellar record in private and public service. His career began in the Tata Administrative Service. He has a degree in physics and a master's degree in management from the Sloan School of Management at the Massachusetts Institute of Technology, MIT in Boston. He has been an entrepreneur and a founding CEO and CFO of 3 technology ventures. And he has mentored a number of new ventures in Silicon Valley and India as a partner and board member of KPMG. His record in public service as Assistant Secretary of Commerce for Global Markets and Director General of US and Foreign Commercial Service in the Barack Obama administration, where he was the lead official in promoting trade and investment efforts around the world. He's a member of the prestigious Council of Foreign Relations in New York, chair of the Indian Advisory Council of the US-India Business Council, and member of the board of directors of KPMG International, and chair of the Audit, Finance and Operations Committee. Last but not the least, Mr. Kumar is a poet with a published book on poetry called Plain Truths, and has co-edited a book, Kerala's Economy, Crouching Tiger, Sacred Cows. Thank you, Mr. Kumar, for accepting our invitation to speak on sustainability in healthcare, a very pertinent topic today, where the pandemic has made us realize that even healthcare is not recession-proof. Mr. Arun Kumar.
Thank you, Dr. Shivnan. Great to be with you and Dr. Saudullah. I must start by saying that I feel extremely inadequate today after having heard those 2 brilliant discussions by both Dr. Rajiv and by Dr. Kochhar. I thought in particular I learned a lot from both of them. So I just want to first of all tell you that I'm the odd man out today. I'm the one person who's not a doctor and not familiar with medicine. But my firm does a lot of work related to healthcare. In fact, our teams have been very active in both at the center and in many states in helping cope with the COVID crisis. So what I'm going to discuss with you really represents the thinking thinking and the work of my colleagues. So this once in a generation crisis has brought opportunities and lessons across a wide array of topics, and certainly right at the top of that is healthcare. Government hospitals in both urban and rural areas, and primary health centers and community health centers in rural areas are leading India's efforts to manage the epidemic. But apart from improving individual healthcare outcomes, there is also a compelling need to construct community healthcare surveillance systems as well as digital tracking systems to keep people safe. I will share with you some perspectives based on a global vantage point, as well as a proud Keralite who believes in the potential of the state. The healthcare landscape in Kerala is ahead in many parameters when compared to other states. In fact, the Kerala model for development is often referred to as an example for other countries to follow. The state has received global attention and admiration for its model of development with its focus on education, healthcare, environment, and cleanliness. Much before Kerala became a separate state in 1956, the region had seen several path-breaking public health interventions. In 1879, the erstwhile rulers of Travancore had made vaccination compulsory for public servants, prisoners, and students. In 1928, a parasite survey done in association with the Rockefeller Foundation led to the control of hookworm and filariasis. So this community health legacy got a further boost as the state's focus on literacy and women's education helped it attain near 100% vaccination levels and develop a culture of personal hygiene. So today, the state ranks first among all Indian states in the Sustainable Development Index constructed by NITI Aayog, which aligns with the United Nations Sustainable Development Goals. The health gains made in Kerala can be attributed to several factors, including strong emphasis from the state government on public health and primary health care, decentralized governance, financial planning, girls' education, community participation, and a willingness to improve systems in response to identified gaps. In addition to the social development efforts, this progress has been achieved because of a strong primary healthcare infrastructure. Though Kerala has only been investing close to 5% of its total state plan outlay on healthcare, which is also roughly the national average in the sector, and less than several states, its focus on healthcare at the level of PHCs and community health centers is noteworthy. Kerala will soon house one of the first medical device parks in the country, focusing on the high-risk medical device sector to provide a full range of services for the medical devices industry like R&D support, testing, and evaluation. Kerala's health policy design in the last decade has been informed by lessons derived from critical research as well as expat movement. An excellent example is Mission Adram, which was launched in 2017 with a view to lowering out-of-pocket expenditure on healthcare that stemmed from an expanding private sector and a growing demand for higher quality care. Interventions under this mission have been designed to encourage the utilization of public healthcare services by enhancing the care-seeking experience at these facilities. PHCs now upgraded to family health centers boast of longer working hours, web-based appointment systems, virtual queues, and they're equipped with better staff and capabilities. The proportion of the population made of adults over the age of 60 is expected to double by 2050. Kerala is already developing geriatric care wards and geriatric-friendly facilities in preparation. The state has pioneered universal healthcare services in the country, and its palliative healthcare services have been widely applauded. Observing its popularity and the growing need for palliative care, the state created a palliative care policy in 2008, and 5 years later required all local governments to implement palliative care. In 2013, the national government used Kerala's policy as the basis for its national palliative care strategy. Kerala thus presents a model of health governance that is at par with many developed countries. But despite these health improvements, owing to the slower than expected economic growth, the burden of an aging society, and the expense of technology advancement, Kerala's healthcare systems are facing new challenges. The epidemiological transition towards chronic diseases, erosion of public health funding, and the continued presence of private healthcare at much higher cost expose a few of the challenges faced by existing systems. The lack of regulations over the private sector does not guarantee the quality of healthcare. Although mortality is low, the morbidity levels in urban and rural Kerala is high compared to other Indian states. Thus, the paradox is that on one side, Kerala stands as the state with all indicators of better healthcare development, and on the other, it exceeds all other Indian states in terms of morbidity, especially chronic illness. Kerala's tremendous efforts at initially controlling the upsurge of the COVID-19 virus won wide appreciation across India and beyond, as the state successfully managed to delay the disease peak through its efficient containment measures. But with overall activity and travel resuming, current levels of management of the crisis appear to be facing pressure. The state must consistently work towards making its people-centric health system accessible, affordable, and most of all, sustainable. An inflection point for Kerala is potentially here, and the state has the opportunity to build on its existing foundation. So let me discuss 5 key themes which should inform the direction of Kerala's journey to make its healthcare system more robust and relevant. First, urgent investment to set up a data-driven national health parameter and epidemic spread monitoring system, which can be used for predictive analytics and preventive interventions. Technological enablement, digitization, and automation are affecting industries today in profound ways, and public healthcare delivery is no exception. The pandemic has particularly positioned telehealth services for mainstream adoption. A recent report by the health tech startup Practo revealed a 500% growth in online healthcare consultations, and almost half of these users were non-metro residents. Second, newer technologies such as artificial intelligence, robotics, precision medicine, 3D printing, augmented reality, virtual reality, and genomics can now be integrated into healthcare delivery, helping hospitals move from reactive maintenance to preventive or condition-based maintenance. With smart equipment can make the existing systems more cost-effective. Third, building a future-ready healthcare infrastructure with a focus on infrastructure design, including the use of sustainable technologies. Since hospitals are energy-intensive buildings, optimizing energy usage and ensuring critical systems function at all times is important. Singapore is a notable example of how intelligent technology infrastructure is enabling health services to grow and meet patient demand with its adoption of a data center infrastructure management solution. The Rebuild Kerala mission offers a great opportunity to leapfrog to next generation public infrastructure, which is interactive, connected, yet affordable, including in healthcare. Fourth, continued investment in human care skills, for which Kerala's nurses and caregivers have earned a legendary reputation and brand equity in the profession. This is an opportunity for Kerala. Establishing world-class training institutions with state-of-the-art facilities, organizational backup, and international accreditation are some important steps to focus on. Healthcare is more than just technology, and Kerala is poised to build on this sentiment. And last, combining legacy strengths with new tools, finding new markets. Kerala is probably the only state in India where Ayurveda is used as a mainstream medicine. The state is home to many Ayurvedic medical colleges and hospitals. However, the main challenges inhibiting growth are standardization, availability of raw materials, and the use of technology. Traditional players like Kotakal and new age players like BIFA have larger roles to play in this area. Further, life science is an area for collaboration of Ayurveda with allopathy. Healthcare tourism is a key segment in the tourism sector in Kerala, with visitors from other countries for healthcare treatments. Several factors, such as the state's location, lower cost of treatments, facilities at par with international standards, and English-speaking medical staff have made Kerala one of the most popular medical tourism destinations in India. To continue building on these natural advantages, the Healthcare Tourism Promotion PPP initiative could be woven into Kerala's tourism promotion efforts, particularly since the state's scenic locales are among the best in the world to practice alternative therapies. The relatively reduced environmental footprint of such treatments in comparison to allopathic treatment, and also the socio-economic footprint of sourcing all things locally, can positively impact the entire supply chain. Fortunately, Kerala's traditional healthcare practices are now receiving a level of international acceptance, with aged care emerging as an area of concern and where the world is discovering the value of Ayurveda. What is required is a convergence of traditional strengths in nursing, Ayurveda, and physiotherapy to evolve an entirely new and holistic approach to healthcare. Sustainability in the healthcare system covers several dimensions, which, apart from the quality of services, affordability, and impact on environment, must also consider elements related to employees, their fair wages, and operating environment. Focused investment, skilling, and continued repatriations from Kerala's expat diaspora can also lead to the creation of substantial employment opportunities. What information technology is to India as a whole, healthcare must be to Kerala. In fact, healthcare has now emerged as the largest industry in the world, pushing tourism to second place. The world also faces scarcity across a range of healthcare professionals. With a focused set of policies backed by concerted action, Kerala can emerge as one of the world's most prominent destinations of high quality and sustainable healthcare delivery. My best wishes to everyone engaged on this journey. Thank you.
Thank you, Mr. Kumar. That was a really insightful presentation, and I think it went along with our topic of the future of healthcare and how we can improve ourselves in Kerala, especially. We shouldn't rest on our laurels as being the leading all the healthcare indices in our country. I would like to now invite Dr. Susan John, who is a consultant at the Department of Clinical Epidemiology here at the Rajagiri Hospital. Public health has always played a central theme in her career, and she has been actively involved in a number of public health activities, including an active role in the Nipah outbreak in 2019. She has worked as an external monitor for the World Health Organization in the districts of Ernakulam and Idiki as part of various immunization campaigns. She has contributed in developing an epidemiological risk assessment for staff and patients during the COVID pandemic. She is a core member of the COVID response team, and her role is fundamental in contact tracing, surveillance, and quarantine. She will be speaking to us on acclimatizing hospitals during COVID, then, now, and ahead. Dr. Susan John.
Please put it on full screen. A very fine good evening to all. First of all, I should say it is a privilege and a complete honor to be listening to a very highly eminent set of panelists. And I would also like to thank the CII for giving me this opportunity. On that note, let me say the last pandemic that shook the world was over a century ago. Since then, we have been having multiple epidemics and outbreaks. But the one where Kerala took note of its epidemic response came in 2011 with the H1N1 pandemic. Further on, in 2018, the world applauded Kerala for containing the Nipah outbreak to just 2 districts in Kerala. The ongoing surveillance system is very effective in Kerala has been proven by the very fact that the first case of COVID-19 in India was detected in Kerala on January 30th, 2020. On this note, I would like to go on to the topic, acclimatizing hospitals during COVID, then, now, and ahead. While by April, many states were staggering with the burden of COVID cases, Kerala had flattened the curve, which was once again recognized worldwide, as mentioned earlier, and this came to be known as the Kerala model of fighting COVID-19. As we all know, Kerala has a population of 3.48 crores, with a high population density of 860 persons per square kilometer, and is the state with the highest proportion of geriatric population. While these factors remain unfavorable for COVID-19, the key factors that did help are the indices, as earlier mentioned, at par with global standards. Let it be the Human Development Index, infant mortality rate, the literacy rate, prior experiences, which as explained earlier. With a uniform policy that has been released by the Kerala health sector, which was being taken up by the 14 districts and implemented at the district level in an effective manner, the public health system with more than 800 primary healthcare centers, ASHA workers, as well as our Kudumbashree workers have effectively helped in maintaining or controlling COVID in the grassroots level. The private sector has not shied away from its burden of COVID-19 cases. Timely as well as evidence-based guidelines from, once again, the Kerala health sector on testing, treatment, and contact tracing. And the occurrence or bringing about micro-containment areas of over 600 of them today, also called as a local self-governing areas needing special attention, have all been key in beating, or rather I would say, handling the COVID-19 pandemic. A simple poster that was being released by the Kerala government emphasizing social distancing as well as use of hand hygiene was to convey to the masses the need for all the precautions in this hour. On this note, I would like to take on a journey on Rajagiri's experience during COVID-19, which we would like to call the Rajagiri COVID care model. Rajagiri is a JCI re-accredited hospital, and as earlier mentioned, quality has helped to maintain in place already annual drills and checklists for management or at least approaching epidemic diseases or response to global communicable diseases. With the knowledge that COVID-19 was here to stay, we expanded the core group to involving key clinical and non-clinical departments. And I should say, since the last 6 months, we have been having daily meetings of at least 15 minutes from these core departments. 2 WhatsApp groups really came into prominence. One group addressing at the point any issues we had with regarding managing COVID-19 in the hospital. And another group that had all the heads of departments across the hospital, so that daily decisions that were taken were communicated to all the heads of the departments, and this was communicated to all the staff on a daily basis as dynamically as possible. All hospitals have a triaging, be it for staff or patients. The unique features in Rajagiri was that we not only took care of the patients that came to the hospital, but even bystanders' epidemiological history was strictly analyzed. As can be seen, our operations staff were given tabs so that all the triaging history was being entered online. And to prevent the overcrowding, as soon as a patient was taking their appointment through the phone or through the online pathway, a FASTag site could help them to enter these details online prior to coming to the hospital, so that a positive history would help us to limit their entry to the hospital. Hand hygiene was compulsory for either staff as well as all visitors and patients to the hospital. And the data so obtained was analyzed for its daily trends. Outpatient measures, that is, we took up mainly giving information, be it to the staff as well as to the patients through our television as well as posters put up on the preventive measures that could be taken against COVID-19 while sitting in the OPD. Transport was a key factor for us. We had designated pathways, be it for shifting a COVID positive or a suspect patient from the emergency department, OPD, shifting a patient for emergency surgery to a designated operation theater, or for taking patients for investigations like CT or MRI. We have lifts which are designated and kept apart for this particular use, and it is not used for any other purpose. All these details are regularly updated to all operations and security staff. And we have learned that prior alert to the destination area makes a big difference while receiving the patient. The Rajagiri laboratory services are NABL accredited. And way back on 17th May 2020, we got approval from the ICMR and from the state government to start testing for COVID-19. We prioritized on safety of both the staff as well as the patients during the time of COVID testing, and also on the prioritization of which patient should be tested first because of the limitation of the kits that were available. All hospitals may have a separate zone for COVID positive patients, but we had a few more high-risk categories. Our COVID suspect patients have a separate ICU as well as rooms, cohorting of patients with influenza-like illness symptoms, cohorting of patients with undiagnosed fever, and our staff who were primary contacts were put on quarantine in a unique area. The challenges that we faced were developing or having separate areas for these high-risk groups across the hospital to have easy access to them and to avoid accidental entry by other patients or staff. What we realized is that for all these high-risk groups, we should focus it on a particular floor, give importance to the lifts from the ER and OPD for quick access to these areas, restrict entry through barricades, and an updated inpatient status in these high-risk areas makes a big difference in managing the situation. Our maintenance team came up with a plan where we segregated an area and put up barricades. Since the last 6 months, we have had over 200 COVID positive patients in our hospital. Our very first case was a 30-year-old stage 5 chronic kidney disease lady. And as can be seen, she was discharged successfully. Since then, we have had a few interesting cases with more than 30 ICU admissions and less than 5 deaths. Our focus areas, as we all know, mainly went on infection control. But we focused on the fact that not only doctors and nurses, but be it our operations staff, housekeeping staff, relations or security staff, all of them were taught how to use their PPE, especially during doffing, because doffing, if done incorrectly, can lead to self-contamination, and that itself as a source of infection. Any case of COVID positive detected among our staff went immediately for contact tracing, and clinical epidemiology was instrumental in identifying the primary contacts and quarantining them inside 6 hours period of knowing the COVID positive status of a staff. Human resources came up innovative ways with continuing training, fingerless punching system, as well as creative leave policies, be it for our staff during who were in quarantine or who turned positive in this time of economic crisis. Telemedicine received a boost in our hospital too, and patients that required follow-up but need not necessarily come to the hospital were actively called or reached back through the telemedicine services. Limiting nosocomial COVID was an extreme concern in Rajagiri. And way back in March, we began our no visitors policy. We started 2 hourly reminders through the mic system regarding the preventive practices in COVID. Leave and travel monitoring through epidemiological risk assessment of our staff was being done. Designated staff had been employed in these high-risk areas mentioned earlier. If there was a development of a COVID cluster in the emergency department, it definitely meant that the Rajagiri hospital machinery itself would literally stop functioning effectively. And realizing the importance of this, we converted our emergency department into a full PPE zone way back. A simple thing as having coffee or having food while relaxing could be a possible cluster in the few days to come. And hence, way back in July itself, we started unique seating arrangements and posters in our cafeterias and in our dining rooms to bring about or limit nosocomial COVID. This is just a slide to put across how very minute details have been considered across different departments while managing the COVID-19 pandemic. As I earlier mentioned, Rajagiri Hospital did not shy away from its burden of COVID-19 cases. There's a major stakeholder of taking up COVID-19 cases in our hospital. We have our very own first-line treatment center. 24/7, round the clock, we are shifting patients to other FLTCs if needed. the training services were being provided to different staff from government sector too, from our hospital, as can be seen in the picture shown. Virtual services are being provided in the Department of Critical Care to different hospitals. Our services did not limit to Kerala, but also we have gone across borders. The Rajgiri Hospital Management manages a clinic in Mauritius, and key lessons that we learned during the COVID pandemic was passed on then and there to La Clinique Mauricien, and they also have been able to effectively implement these practices. Just a quick glimpse into the COVID-19 scenario today. Globally, we can see we have more than 35 million cases. Cases are steadily rising. But a look at the death rate do show, even with the increased number of cases, we have tried to hold down our death rates in particular, which probably gives an indication that our effective preventive measures have been effective and it is being implemented worldwide. Though India stands second with regard to number of cases, we must remember that India is the second most populous country in the world. US has already reached its second peak of COVID-19, while we have reached our first peak only. In India, Kerala stands third among the states, but again to note is its very, very low mortality rate. Again, the number of cases or the surge in cases in Kerala is a concern. But if we look at the number of people who have been sent on quarantine, it gives us a look into the fact that the surveillance system is working very effectively in identifying primary contacts of the cases and thereby sending them on quarantine. The test positivity rate has been another point of concern, as it has been readily increasing. As we all know, out of the total people tested, how many of them turned positive? But if we look at the very next graph, the growth rate of infection has shown a drop in Kerala. This is again indicative of the fact that we are quarantining and testing people who we strongly suspect to be of COVID-19, and we are not shying away from the number of tests that are being done. Kerala does almost double the number of tests that are being done in the average in India. And the mortality rate, as I earlier mentioned, is extremely low when compared to that of India. New Zealand probably would be an excellent example for us to take lessons from. Different measures, be it border control measures, community transmission control measures, case-based measures, and health well-being measures were being taken up, all of them very strongly during the peak of the pandemic. But as the peak subsided, community transmission control measures like cancelling public meetings, restricting gatherings, stay-at-home policies came down. But even when it came down, border control measures and case-based control measures, mainly focusing on contact tracing and surveillance, still remains strong. And this is probably a lesson we should take up too. The 1918 flu pandemic showed a pandemic age shift from the elderly, with regard to shift of mortality from the elderly population to the younger population. It showed a series of 3 waves, from a mild spring wave to a pandemic wave and a final lethal wave, where the pandemic wave had more number of cases which were more lethal. Probably a similar pattern could be noticed with an increasing number of cases in the US with its second peak. Then too, they had gone for blood transfusion, vaccines and sera. But the lesson that we had learned from the 1918 pandemic was that non-medical interventions such as quarantine or isolation, if done effectively, is key in controlling the pandemic. Another key lesson that we did learn from them was that a person who developed disease just 4 days after the onset of the outbreak died, while this person who developed disease 4 weeks after just had a mild presentation. So in 1918 pandemic, slowing down of the virus by isolation had a role. In the current scenario in India, we do observe through contact tracing that the larger number of primary contacts are females of younger age. A higher secondary attack rate is found among high-risk contacts, and based on place, it is the household contacts definitely, even by sense. But we must equate to the fact that household contacts should be similar to our workplace. As we open up our workplace, what are the interactions? Will we let down our guard? And could that lead to an increased secondary attack rate? Again, sharing of the same conveyance, as earlier mentioned, as an AC bus from China, more than 6 hours has a secondary attack rate of 79.3%. Another interesting point was that just 0.2% of the cases contributed to more than 80% of the contacts, the index case in the younger age group. So our behavior in the community has a definite role with regard to transmission of COVID-19. The factors that were seen with mortality were males, increasing age, presence of comorbidities, and testing early in the pandemic as seen or similar to the 1918 pandemic. Children, they're asymptomatic, but are they a source of infection and transmission in the community is definitely a pointer in our pandemic too. For the future, what we do see is the role of modeling. Different models have been brought up, and they definitely help us to have an idea of what might be the future and have our preparedness in place. But modeling is not an exact science by itself because any changes, be it in the host, a mutation in the agent, differences in the environment can change the actual picture. Nevertheless, modeling is a tool that must be used with care and yet must be used well. Currently, we have 42 vaccines in clinical trials and 151 of them in preclinical trials. And of the 42, 10 of them are in phase 3 clinical trials, giving us hope. Use of sanitizers, masks, and safe distancing still remains critical, as our earlier speakers have well mentioned. And again, just like this platform, IT innovations must come into place, maintaining social distancing and yet keeping the global machinery running. As again earlier mentioned, we must give us focus back onto the sustainable development goals, focusing on our burden of non-communicable diseases, as well as the first and second goals, again, with relevant to the second most populous country in the world. Poverty and hunger are important problems we must address and should not leave them behind. Probably, I should once again remind that a tiny invisible virus has brought the entire global machinery almost to a standstill. So as the peak probably will subside in the near future, we must not let or throw our caution to the winds, but must bring about our surveillance techniques should always be strong. Keep it always in place to pick up all the trends so that we know what we are dealing with. And hence, I would like to conclude by quoting Mr. Woodrow Wilson, "We shall not, I believe, be obliged to alter our policy of watchful waiting." Thank you.
Thank you, Dr. Susan. That was a wonderful presentation. I think we have a couple of minutes, Dr. Sadullah and Dr. Deepu. Can we take a few questions from the audience?
Maybe one or two at the max because it's almost 18:12.
So is there any question from the audience, or can I ask a couple of questions?
You can go ahead and ask, please.
So can I ask the first question to Dr. Jayadevan, please, on policy issues that he has highlighted? I just would like to know that, this is a very heterogeneous population and a vast geographical area that we are dealing with here in India and globally. And, the government has to be the nodal agency because it has to coordinate all these efforts across sectors. So what do you think? Is it possible to have a coherent policy right across all the states? We don't seem to have it even in the states itself, and Kerala has its own policies, as do other states. And of course, international travel is restricted, etc. So what do you think is the future regarding having a coherent international policy?
Yes, as you rightly said, Kerala is geographically distinct and culturally distinct. And as with other states in India, each state or each region in each state has its own personality. So India being such a large continent, we really can't have a single policy for many things. It needs customization based on local data and local preferences. We need to have local studies, local audits. One of the things I see missing in this country is that we just don't do enough audits. Audits can be something very simple, including what do you think about what we're doing? We just don't have them. We rely primarily on material from the internet and try to extrapolate what's happening in Spain or Sweden to our country. What we need is local data. And the answer to your question comes from local information. You're right. It needs to be customized.
With the financial stress that is faced by the healthcare sector, and it seems to be taking a lot out of all of us because in terms of sustainability, as you were mentioning, so it's a huge challenge. We are 10 months down the line since the pandemic started, and it doesn't seem to be anywhere nearing its end. So how do you think that hospitals, the healthcare sector itself, can reposition itself to get back on the growth trajectory?
I'm sorry. The question is addressed to?
Mr. Arun Kumar.
Okay.
Mr. Arun Kumar, could you hear me?
Yes, I'm coming on. Yeah.
Could you hear me?
Yes, I got most of your question. And the question was, given the financial stress, how do you get back?
That's right.
Well, it's a common problem with a lot of businesses. One thing I'm finding is many businesses have figured out how to adjust to the new situation. So I would have thought things were much worse, but I think people are beginning to adjust to the new situation. And for the healthcare sector, this may be a place where there should be some targeted government assistance, as has happened in many countries. Could be a combination of providing some credit support for the banking and the financial system to support hospitals and healthcare systems. Could be some form of subvention or stimulus. But those are the kinds of things that should be considered. Because clearly the healthcare sector is under stress, and the whole country is going to be under stress.
Thank you so much. I think we'll stop here because it's 6:15. And thank you so much, all the speakers, Dr. Rajiv Jayadevan, Dr. Atul Kochar, Mr. Arun Kumar, Dr. Susan John, and of course, Dr. Saadullah, for a very interesting session. And I'm sure the audience will have got a number of insights and very useful information. Thank you very much.
Thank you. Thank you.
Dr. Saadullah, over to you.
Yeah. Thank you very much, SK Nair. That was a good session, except we could not ask the audience to ask, a few questions. They lost the opportunity. But I again, along with you, on behalf of CII, thank all the speakers and Rajiv, Arun, Atul, and all of you, and Susan. All of you were wonderful, and thank you very much for joining us. Hope to see you in other Zooms very soon. Thank you.
Thank you, sir.
Dr. SK Nair, also thank you for moderating it.
Thank you, Dr. Saadullah, for the brief introduction for the first panel and also welcoming the panelists. Let me, on behalf of CII, let me welcome Dr. Ajit Doi, Managing Director of DDRC, to start and convene the next session. Welcome, Dr. Ajit, to the session.
Thank you, Deepu, and a very good evening to all of you. And welcome to God's own country. Today's session is on collaborative partnerships with healthcare delivery, the mantra for success. So in this session, we have a lot of eminent panelists. How we plan to hold the session is like we have picked up around 8 to 9. See, it's a very vast topic on how to collaborate. So it would be prudent to pick up around 8 to 9 topics, go by. So I would like to introduce or welcome Mr. Jose Dominic. His name is well known in this industry. He's a hotelier, co-founder and director of CGH Health, CGH Health. He was the managing director and CEO from 1978 to 2018. Currently, he's on the director board. Welcome, sir. We have Dr. Uma Nambiar. She's a well-known neurosurgeon. Started a career from Sri Chitra Institute. She's held numerous posts, right from in the managerial sector to up to CEOs, and currently she is also the executive director of GM Care Hospital in Kannur. He was also the co-founder and chairperson of Digital Health India. Other than that, a list of is a textbook herself. And welcome on board, Dr. Uma.
Thank you.
We have Mr. S.K. Abdullah, CEO of VPS Lakeshore Hospital, who's an advocate himself, 30 years of experience in the healthcare field. And he's heading one of those largest and upcoming global healthcare enterprises. Welcome on board, sir. We also have a very experienced person from the insurance and healthcare with a lot of experience in third-party insurance handling. I would like to welcome Mr. Gagan Kapoor, who was the co-founder and chairman of the Quebec Health and Medicare Insurance. His family used to run, a family business of TPA services, which used to hold a total turnover of more than 900 crores. So, welcome Gagan on board. Gagan.
Thank you.
We have with us Mr. Rajiv Vasudev. He's the founder and CEO of Ayurveda Hospitals and also the chairman of the CII Ayurveda Group. Other than that, he's been an active participant and leader in the work of Ayurvedic fields in many areas, and I will detail it in the course. So, welcome on board, Rajiv. Rajiv, are you there?
Very much, yeah. Can you hear me? Yeah, very much, yeah.
And finally, myself, I'm the chairman and managing director. Already Tipu had introduced me. I'm a nuclear medicine specialist by profession, like qualification. I am also involved with, research and development of numerous new technologies in various startups. So coming on directly onto the topic that we have, which is a very vast topic, we will focus ourselves. At this point of time, I'd like to think of an analogy. Kerala, when we look at, has all the goods of being, God's own country, the best of nature, the best of education. If you compare it, the lifestyles, if you compare the healthcare sector, excellent primary healthcare sector, we produce the largest number of doctors, nurses for not only the state, but also we export the expertise in healthcare in many walks of life across the globe. So in such an instance, why are we not being able to harness and harvest this potential at state was the main concern where such a topic came up for discussion. And, I can only think back to look at, it is the World War II which brought out the best in most nations. Until then, they were all isolated and they had their own agendas. When a crisis came up, we all got together they all got together and started to collaborate in the best ways in the most minimalistic of times to bring out maximum results. Currently, there is a COVID pandemic where things have shifted, and that has actually put us all together in large numbers on a web forum to discuss where we would have been in lesser numbers. So coming exactly to the first point in our discussion, we have many a times discussed that healthcare is very synonymous when it comes to medical value tourism. Organ transplants are the first thing that come to mind. So when in organ transplants, why is it that we as a country and as a state cannot capitalize the true potential, and we are just only at a very meager or minimal level of the entire market cap? So I would like to put this question to Dr. Uma, who has been in the heading multiple hospitals in the country and in multiple other forums also. So Dr. Uma, would you like to start your views on this point?
Thank you, Ajit, and thank you, CII, for holding this discussion and bringing us all together. And if you see the good, bad, ugly of COVID, the only good I can see is that all of us now meet more people than what we have ever met before. Very happy to meet everybody in this forum. So Ajit, when we think of organ transplant, what is glaring is that despite such a huge requirement in the domestic and international market for organs for patients who are deserving, and there's a long wait list, Kerala is singularly missing on the map. And it is not because we do not have good hospitals, and it is not because we do not have the talent. The skill set, the centers of excellence, the capability, there is no denying that it is as good as anywhere else in the world. But what is it that is missing? And so if you really look at, organ transplant is, yes, it is a team approach, but it is not just a team within or inside the hospital. It's a team that requires the government, the regulators, the transport people, the civil society, all to come together. Then only organ transplant can succeed. So I want to draw a parallel between us and our neighboring state, Tamil Nadu. Tamil Nadu today runs one of the best, it's really exemplary the way they run their transplant service. And this is not today. I was heading one of the centers which did the maximum transplants in Chennai way back in 2010. And you should have seen the excellence with which the transplant services run there. The registry that is required, the government had a registry to keep a list of all recipients, potential recipients for every organ. They had, their transplant cell was very well networked. They knew where an accident happened, where a death happened, wherever there were brain dead patients. There was absolutely, the system was seamless. You would have a death in Trichy, and in the next 3 hours, there would be a heart available in Global Hospital, lung available in Apollo, a pancreas available somewhere else, 2 kidneys going to 2 different hospitals. I mean, this was marvelous. You would find that a patient dies, and at least 5 to 7 patients in 5 different hospitals got transplantable organs. This requires a logistic support which needs to be centrally monitored and governed by a system within the government. It is not possible for a single NGO or a single hospital or even the team of hospitals to come together and make this happen. This requires your transplant cell coordinator and 24/7. You could call the transplant coordinator, Mr. Amol Parvanathan, who actually made that happen, at 3 o'clock in the morning. He would call you at 4 in the morning and say, ma'am, you have this patient, can we send this organ? I mean, it was so seamless and so well done. Why is it that we can't do it? So there is a problem that I find here, and I mean, when I see our civil society is not very active. I mean, I would really want to know from people who are attending this webinar, how many of us have a living will which clearly states that I would like to donate my organs post my death? I have, because I know that I can save 10 lives when I die. And I would like to live through those 10 people. And that's very important. So it is not the government alone. It is not the hospitals alone. It is not the doctors and the nurses alone. Large part of us, all of us individually have to be responsible. And I think civil society needs to take it up. How many NGOs in Kerala work towards promoting organ transplant? We have enough hospitals being shut or the transplant programs being shut in Kerala because somebody says that the hospital is killing a patient to get a kidney. And for heaven's sake, I don't think hospitals are in that business. How can an educated population from Kerala think like this? So it is a shameful fact that being the most educated state, we still do not have a reasonably good organ transplant program, which should have been the best. So I think let's learn from our neighbors and let's understand where have we gone wrong and really put it right. The other thing that is very important is also to understand that the money required for transplants is huge. So can we today, or at least think that can we look at some innovative financial models that can come up to help the patients who require transplant. Kerala is the capital of the country, or in fact soon going to be in the world probably, in terms of diabetes, in terms of alcoholism. So look at the number of kidneys and liver we require within ourselves. So let's not look elsewhere. Let's also try to look at some financial models. So, and also make it help for people, because some of them would have drunk themselves to poverty and they need livers and kidneys. So let's look at all these. Let's really be sensible and make a viable financial solution as well for the population that requires all this.
Dr. Uma, you brought out the real crux of the issue here. It is not, the lack of organs. It is neither the lack of will to donate. It is the consensus and the collaboration in a state, a very educated state with governance and a common platform that is missing to handle this entire endeavor that is being lacking. And that is one of those major points and takeaways that we should take from collaborating together to bring it onto the point. At that point where you stopped at telling about the financial aspect of the organ transplant, I would like to bring in Gagan, who has been instrumental in insurance as well as TPA, and he's been a banker too. So Gagan, would you actually share your views on the aspect of how to solve or leads towards that problem?
Like Uma said, and there is a huge vacuum in India or about organ transplant and how to finance it. But what we are seeing currently, insurance companies globally are moving towards a more structured approach and are looking for various mechanisms to have or assist their members. The only point that the insurers are looking for, because at the end they're also trying to make money, right? So they will not take a ailing patient. They would take a patient who's been there with them through the journey, and then basically if he has any such failures or requirements, they're always there to support. The structures need to be in place to facilitate this in a more organized manner. I mean, in India, the insurance penetration is fairly low, though Ayushman Bharat has tried to increase the penetration level, but still organ transplant does not form part of that, right? So I still think it's early days for insurance to come and back that. But in where it's penetrated, they are fairly supporting this cause, but they need a structured solution to deliver this. And also, we are seeing a lot of international support by insurers or universal healthcare systems trying to support these services in other countries because of the pressure that they are facing in their countries. So that's an opportunity that we should also explore in a more structured environment. Ajit, I think you're muted.
Oh, sorry. Gagan, is there an option where the NHS, like a model, where end-to-end coverage of medical insurance from an early date can take care of that at a later date here? Yes, NHS insurances and European insurances do have their problems, but can insurance itself, when it in a full-blown coverage, take care of this? And as well as that, would there be another aspect? We do have such a model where even the foreign patients are catered to through coverage from abroad.
So, I mean, if you look at the NHS and Medicare, Medicaid, they're actually already supporting such activities and are looking at and are actually currently overburdened with their ecosystem, and hence are looking for a structured approach where they can approach other countries to reduce the burden, because the waiting period in all these countries, the UK or the US, is very high. There are huge chances of a person actually dying before he receives such kind of support. So we have been able to talk to both couple of states in the US and also with NHS, and they are looking for some more structured approach in which they can approach countries like India or states like Kerala, where they can assist their people in getting such transplants done in a more economic environment. And if you look at it from an Indian context, the private health is the only one that is currently covering transplants, and there has to be a structural effort. But given that the penetration is so low, most of people don't have insurance. The average insurance in India is between 1 to 2 lakhs. If you take the whole population, that's the sum insured that they have. With 2 lakhs, I don't think you can get anything transplanted in that. So that's the challenge that we're having. Though Ayushman Bharat has come up with a 5 lakh sum insured, but we're hoping that transplant will be covered in a future date with them.
What needs to be done on that? Okay.
Yeah, exactly.
In this aspect. So now, if all agree, we'll move on to the next question. Then when we actually mention medical value tourism or medical value travel, the first thing that actually comes to mind to all of us is, do we have a lot of good hospitals, good qualified people, and good infrastructure to handle all that, a beautiful place, the hotel industry, the Ayurveda tradition, and lots of other pluses. But do we actually have the minimum requirement of infrastructure? And do we have true governmental support in this? So I would like to put this question to Mr. S.K. Abdullah, who's leading one of those global healthcare groups as in VPS Lakeshore, where they have hospitals in the UAE as well as here and globally elsewhere. So could you give some direction on to what our roadblocks are in this this area, and how could we handle that?
Thank you, Dr. Ajit. Good evening to all. Before answering this question, let me congratulate the CII Kerala chapter for organizing such a wonderful platform in a very well-fashioned manner. Kerala Health Tourism, of course, and conference and exhibition has evolved as a major platform that deliberates on the strategies for the future growth and innovation of healthcare sector in Kerala. I appreciate the constant effort of the office bearers of CII for their determination to strive for the excellence. Regarding medical tourism and our journey to make Kerala as a hub, our friend has already handled that one. Kerala has been able to attract very smaller proportion of the medical tourists visiting India compared to the other cities in India. Why? Medical value travel is one of the best means to earn the foreign currency, but we have failed to attract the bulk of that share. As far as Kerala is concerned, every is a story of lost opportunities, I should say. Currently, every hospital promotes themselves not as a Kerala. Every hospital promotes themselves for their specialty and for their treatment, but not Kerala as a destination. For there, we have to have an organized platform to, to promote Kerala as a destination. Now, today we have an organization, Kerala Medical Value Tourism Society. That society should join hands together with the CII and the government of Kerala for a comprehensive and organized flag of MVT. An umbrella organization and the government can bring in striking changes in the whole scenario. The point is, MVT should be given equal importance, which is given to Kerala as a tourist destination. We are talking about the God's own country and best educated and all those things. But we have not, given that importance as a MVT destination to Kerala. As this requires organized effort, tour operators, facilitators, even international agencies should come under one structural format. A combined effort should be taken to conduct at road shows to attract MVT patients from other countries, especially from Africa and CIS nations. Their air connectivity from, and now regarding the roadblock and all those things, I should take up the points regarding the connectivities. In Kerala, we have got 33 hospitals with NABH accreditation, which is the highest in India, I believe, if I'm not wrong. Connectivity is one of the major issues, as most flights, except the ones from West Asia, operate to cities such as Mumbai, New Delhi, and Chennai. Most of the foreigners who come to Kerala are only from Gulf countries. Although we have 4 international airports, it is the time to explore the opportunities to have more flights from other part of the other geographical regions, and the industry and the authorities can look for options to have it. Alternatively, to launch offer combined with the airlines industry. I should say launch offers with airline industry. Faster and comfortable intercity, road and railway connectivity for MVT is also very important. Alternative therapies combined with the tourism destinations, which will be handled by our front. Then if we come to regulatory health, and that is visa, consulates and all those things, we should not equate medical tourists with international tourists. Medical tourists are different, international tourists are different, patients are different. Medical visa should be given on arrival. Lowering the cost of medical visas should be the focus point from the focus countries. Indian missions to be opened in countries within high potential regions like Africa and Middle East, especially Somalia, Yemen, which have high potential for MVP. Focus on boosting exchange of leading healthcare practices, skilled healthcare workforce, and technology with countries averse to issuing medical visas in order to allay their concerns, especially from CS countries like Tajikistan and Turkmenistan. Medical visas for patients from countries like Pakistan and Bangladesh with stringent issues, it should be eased. We will be getting more number of patients from Bangladesh if the visa formalities are eased. But regarding the local regulations, address barriers around food and language by developing resources like translators, chefs with international cuisines, tourist-friendly approach locals. Also, issues like cleanliness, hygiene, safe drinking water. Though we are talking about the very God's own country and all those things, that phase is getting phased out. Especially with the new infections, which is going every day, escalating with every day. Overall safety of the host country are critical issues for international patients, especially from developed regions. Now, if you are talking about certifying a licensing of agents, an independent body, NABH or ISO, to conduct the accreditation for the license as a licensing agents. List of registered facilitators to be made available on medical tourism websites. Even MVT hospitals may be mandated to display list of registered facilitators in their websites. Medical facilitators need to evolve from sourcing patients to facilitating MVT. It should not be the sourcing of patients. It not be hijacking the patients. By investing in value-added services like dedicated call centers for addressing medical and non-medical queries in different languages, help around logistics, technology for patient data management, etc. Then if you are talking about the ICD codes, if we go for the coding system in our local hospitals in India and Kerala, we can convince the whole world we are at par with the international standards. Regarding the validations and the approvals, coordinating with the source governments to strengthen institutional tie-ups to boost MVT numbers. Difficulty licensing process for medical camps by foreign doctors is another issue. Delays due to lengthy process and exorbitant visa expenses is another issue. These are the things which we have to tackle with. For that, we should have a unified effort by the hospitals, by the government sector, by the agencies, by CII, by the KVMT society and all those things. I think, I have covered the question, and I hope Dr. Ajit can take it further. Thank you, Dr. Ajit.
Thank you, Mr. Abdullah. That was, I know it was a tough question, and it cannot be just summarized, but you have touched most of it, in a very, very, very elaborate manner. But each of that is content for a discussion. And absolutely, it's covered in a fast manner, but all points have been covered very well, and I hope CII can play the mantle to take it forward in each of these, or working with the government on sorting and addressing all these issues. So let's come to the next of our worries. When we say the name Kerala, Ayurveda is synonymous with it, and when we say healthcare, when we say tourism per se, Kerala, God's own country, is synonymous with that. And so, we have in our panel today, Jose Dominic, and very visionary, entrepreneurial, and established hotelier from the hospitality industry. And let's hear from him on how we can synergize between these two diverse fields of globally. The synergy has been going on in many nations. In Kerala, his passion, and he has focused on highlighting integrated medical tourism, which he is actually shown as a model where in the hospitality industry it can be worked out. Furthermore, can such models like in Thailand or in Singapore, where they have a hotel as well as a hospital in combination, be worked out? Or do just wellness Ayurveda or wellness tourism be one part of it, or can we actually combine more complex kind of medical value tourism towards hospitality, as in oncology and many other, where the tourism element of hospitality and the hospitality element of medicine can come together to combine? So over to you, sir, to elaborate on the roadblocks and how to go about this.
Dr. Ajit, I guess Dominic has dropped out. I'll connect him. Probably you can take the other question to other panelists, please.
I didn't see that. So, okay. So we'll move on to the next question. Again, let's say now how to come into.
Dr. Josh Dominic has just joined back.
Yeah. I think we can hear from him, then move on. Sir, I do not know if you heard what I had mentioned, but it was about the synergy between the hotel industry as well as the healthcare industry. How do we take it forward in a very synergistic manner?
Thank you, Doctor. Mr. Abdullah had actually covered a large part of what I have to say, but let me just cover here, tell you from the point of view of the synergy which Kerala tourism and healthcare. A moment, if you allow me, I'll just go back into the story of tourism. As far as post-independent India, Kerala, tumultuous state, and in speaking very shortly, red kept Kerala green. What I said is that it kept the smokestack out, and our investments in healthcare, education, in short, human development index, is the dividend of that was tourism. And what Kerala did was the small entrepreneur did what he could, which is small, in a manner that he knew, which is local. So indigenous and small became the flavor of Kerala's development. And the big story here is, though indigenous and though small, it became world class. And that is Kerala's story in tourism. And from there, and integrated with the traditional wellness or well-being and Ayurveda. And these became two powerful forces joined together. Here is where I must say that two things happened. One is relying on traditions and our culture, and the other is on modernity of modern development. So in tourism, it has worked remarkably well. In the beginning, when I entered tourism from when I came back here in '78, our share in international tourism in Kerala was about 1.3%. From that time till 2017, we must have grown from 1.3 to about 22%. from 25,000 rupee earning, 25,000 people arrivals, we've now gone into both in domestic and international, into several crores. So a transformation, a miraculous transformation has happened there. And it's along with that was the synergy and co-currently was as Ayurveda grew. The proposition Kerala had was, as far as tourism was concerned, environmental and responsibility and social equity. So with these two was our inherent strength. And when we came into Ayurveda, there were the two diverse requirements. One was ancient traditions, two is modern evolvement. And so in a way, we grew and created a product in tourism which is unique in India, in fact unique in the world, and we have got recognition globally as a responsible tourism destination. Now, on the other hand, when we bring in Ayurveda, and I remember some years ago, we had a summit which is called Emerging Kerala. Sam Pitroda was the one who declared, famously said, Kerala can be the Ayurveda capital of the world. And it is so. You say the word tourism in India, the word that comes first to people's mind is Kerala. You say the word Ayurveda, the word that comes to people's mind is Kerala.
Dibu, did we lose him?
Yeah, I guess we lose him in between.
Okay. Could you just try if is he?
Yeah, I'll get him back. Meanwhile, you can go with other questions, please.
Okay. So in this juncture, we have with us Rajiv Vasudevan, who is, Kerala is synonymous with Ayurveda, and we have Rajiv Vasudevan, who actually runs Ayurveda, the Ayurveda hospitals, and co-founded it and founded it. So he is involved in Medanta in Delhi and with the Aster Group. He runs 3, and he closely works with modern medicine. And contrary to the facts that there is a lot of space in Ayurveda, so if you could contribute your views to the synergy between hospitality, wellness, and Ayurveda, as well as the modern medicine, it would be great.
Yeah. So first, Dr. It's a pleasure to be here with the esteemed panel. But the mistake that we do is term wellness. Why is that? And so many other things, therefore, that we dilute the value potential of Ayurveda. So let's then go back to what is essential. If you look at what John spoke about, hear me? Are you able to hear me?
It wasn't broken. Now you're okay. Now you're okay. Please go ahead.
Yeah. So I think what I wanted to say is that looking at it as a serious healthcare system, what we should understand in the context of integrated medicine, that whole area that we speak about. If you go at Yale, you look at Columbia, you look at Mayo Clinic, you look at Sloan Kettering. Everybody has got Duke. All the top Ivy League university medical institutions have an integrated medicine program. How do they define it? They don't equate it with alternate medicine. You go to the Duke University site for integrated medicine, you'll see they tell it is personalized care beyond symptoms. It's long-term, complex care, looking at all dimensions of healthcare so that you are able to achieve total health and well-being, going beyond disease reversal to well-being. So it's a much bigger opportunity that we see in integrated medicine. Now, if we were to therefore look in the context of Kerala and Ayurveda, right? Where is the integration possibility? First of all, the stage of the disease. So a given disease at different stages can be better managed through different modalities, right? So the early stage, pre-acute, pre-emergency, Ayurveda could play a very good role of secondary prevention, right? And whether it is for the local community or whether it is for a global community seeking that. If you look at risk mitigation, where does integration come? That I use modern diagnostics to be able to rule out certain risk factors before I apply an Ayurveda Panchakarma therapy. So that is one type of integration. Differential diagnosis, measurement of clinical outcomes, whether biomarkers or other types of established clinical outcomes. I want to bring 2 or 3 areas quickly that if you look at comorbidities, when typically a person comes, we are seeing people, we assume we put a label of one disease, but people typically present themselves with multiple specialties. And let me clarify, we run 4 hospitals on our own. So we have 7 hospitals in total. 4 of them are NABH accredited. 1 of them is JCI accredited. So, we partner as well, and 3 of them. So if we look at comorbidities, it's an excellent area for integration. We're not talking about mixopathy. I want to clarify. Integrated medicine is not mixopathy. It is not an Ayurveda, very strongly feel Ayurveda doctor prescribing allopathy medicine, allopathy doctor prescribing Ayurveda. That is, something very dear to some minds. But I strongly believe each has got their own, respective areas of strength. They should stick within that and help each other appropriately. Because what I learned in 5.5 years in one specialty, I cannot obviously learn when I'm learning another system. So look at comorbidity care. You can look at separating these roles between multiple systems, but through a collaborative, like your tumor panels or the panel of doctors who are able to manage together, right? Palliative care, adjuvant care, where if you're looking at some surgeries, pre-surgery, post-surgery, Ayurveda can really help in terms of. So the concept of adjuvant, where modern medicine serves as adjuvant, Ayurveda serves as adjuvant, is a very good possibility. Internationally, they're using it typically for cancer care, pain, chronic fatigue, fibromyalgia, etc. But let's look at, I just want to bring this point as I conclude my initial remarks. See, when you look at integration, one way to look at it is to say, what does modern medicine do, which it cannot do, what you can bring Ayurveda with? And what Ayurveda cannot do, what modern medicine cannot do. But I want to posit a different vision for Kerala, right? Kerala has that unique strength. We have top-class quaternary care, tertiary medical facilities, top doctors, world-class facilities, right? People still go to other places. Ayurveda, capital of the world is Kerala. How do you marry these both? By offering solutions which are attained only by bringing the 2 systems together. Modern medicine cannot offer a solution there. Ayurveda alone cannot do. If you look at that category, let me list out a few. Take pediatric developmental disorders, right? The entire stretch of spectrum of pediatric developmental disorders. Today, all the other states may compete for other types of surgeries, but if you bring care, long-term duration, high value, pediatric complete range of that. Neurodegenerative conditions. The complete range of apart from deep brain stimulation and stem cell therapies, such a range of activities which can be done in neurodegenerative through integrated care. The world will come to us if you are telling we have an integrated program where you have the modern neurologist and Ayurveda, a physiatrist coming together to really do things. Look at cancer care, metastatic conditions, take any type of metastatic conditions when you've already spread. How do I increase longevity? How do I improve quality of life? Look at solid tumors. Look at stage 1 breast cancer or old patients where you cannot do the chemo radiation. Can I come with more conservative management before I go to something else? Look at cancer survivorship. Globally, the people who have finished everything can come to Kerala, do a survivorship program. Traffic accident, rehabilitation, infertility, right? Globally, huge market. But rather than just do the IVFs and similar procedures, tremendous opportunity to combine, particularly where the cause is not known, right? 40 to 50% of infertility is idiopathic. We don't know where it comes from, but where the man and woman are both okay, come with a program which says that the best of gynecology, I have the best of IVF specialists, and we have Ayurveda together coming to really create the best possible care. Look at bariatrics, right? Take the zone which is not ready for bariatric surgery. Take that is BMI greater than 30, less than 40, that golden zone in between. The whole country is missing that opportunity. Offer that as a very good solution, pre-morbid obesity stage, mental health, de-addiction, and the complete syndromics conditions. You talked about diabetes, thyroid, any endocrinology issues, dyslipidemia, lifestyle disorders, huge opportunity. So I just want to say, when you take these areas, within India, Kerala can come and forge a completely new vision as a healthcare destination, because there is a old Boston concern. Services, new service. You take that completely. An integrated medicine model will allow us to break into a totally new marketplace where we are one amongst the whole world. Nobody will be able to compete with us. So I feel there's a very clear vision that is possible, and we need to. I have some suggestions. Maybe I'll leave it for next step. Yeah, assuming that. Thank you, Dr. And just
Rajiv,
to add, Mr. S.K. Abdullah spoke some. If I can just take 30 seconds, Mr. Abdullah spoke some very relevant points. And I just wanted to bring in that part about the role of the medical value travel segment, the channel partner, right? He talked about accreditation, transparency. Unless we develop them as a specialized channel, which will reach us into new markets, right? And the concept of an Ayurveda medical value travel here itself. And I think CII is taking the lead in that respect. So I think everything that Mr. Abdullah said is, I kind of really echo that. It was very, very important. And I just wanted to say there is a volume versus value game. And we need to play both ends. Large volume, lower price, unit price, and medium volume, but high value. Both these possibilities are really there if we can integrate together. Thank you.
Rajiv, the message that you are giving all of us is there is ample opportunity without, infringing on any other's territory, and to start working together, documenting the facts, and see, in certain areas how it helps each other in a definitive manner. And you have quoted examples of, autism to post-stroke to X and Y. So approaches that we can do. So definitely the external world, the Western world itself is looking at it. So, and this is something that was born here. So, why can't we do it here? That's a very valid thought, and there is room and time, high time that we collaborate, integrate, and document, authenticate, and then go forward in a very, very repeatable manner. And like Dr. Abdullah said, Mr. Abdullah said, like spurious players or the quacks needs to be put. The fast buck players in this that is there in any field person needs to be controlled. So painting the right picture to gain trust of the inbound tourist is the major challenge, be it modern medicine, be it Ayurveda, be it anywhere. So can we actually move on to the next question? Or would Dr. Uma like to come on and comment on your views on this too?
I fully agree with what Rajiv has said. Kerala is uniquely positioned to utilize this opportunity, having been tagged as the best in Ayurvedic care. It's very strange when you talk of best health indices in the country, Kerala, compared to compares as much as in Scandinavian countries, better than some of the WHO given goals. We have all that, but nobody thinks of Kerala as a center for excellence in any discipline in modern medicine. Now, is it because we didn't market it right? Have we missed that bus? Probably yes. Because none of the, we have excellent hospitals there, each one better than the other and as good as anywhere else in the world. So if we have missed that bus, do we have the time to start all over again? No, I don't think we have the luxury of time. So we have to now utilize and make a package for that integrated care. And I fully, I mean, I echo what Rajiv has said, is we also, and it is not just a marketing gimmick. We need to truly believe that if there is a person with an ailment, let's say a non-communicable disease, both Ayurvedic disciplines and allopathic disciplines, they offer complementary care. So there is room in us to package it because we know both very well. So it is only because of our knowledge, and we can put together a forum of learned people who can, make the package for people and say, this is integrated personalized care for a particular disease. So there's nothing to, I think we should take the lead and we should literally, move really fast forward this agenda that we have.
Thank you, Dr. Uma. That's the right approach that I think we should take, and the policymakers are listening to what we have to say. We should have had somebody from the government because we had a lot of other topics to take up directly over there, but I think CIA can be the conduit to take it over there. So, moving on to the next question, medical insurance. Even though Gagan covered a little bit of it earlier, I would like to ask this pivotal, direct question that has, been there. Medical insurance is the cornerstone of the healthcare delivery system, and the efficacy worldwide has improved after the whole system. There has been number of medical insurance. In India, the insurance system is slow. So what should we adopt, and what is being adopted globally, and what should be our approach to insurance to cover healthcare costs? We know the healthcare facilities are high cost facilities, and to create a world-class facilities and to deliver this treatment, it costs. So how do we and insurance is the practical solution worldwide to cater to costs which is accessible and deliverable. So how should we go about this? So this question I would like to again bring it to Gagan. Gagan, could you take this? And before I, there is, in India is the only country where we don't have OPD-based insurance coverage. Daycare is in there, and only IP-based coverages are there. So can you actually take this question, Gagan?
Thanks, Ajit, and I'd like to thank CII for this opportunity. Like you rightly mentioned, I mean, out-of-pocket expenditure, I would like to focus more on out-of-pocket expenditure because, that accounts for 62% of all healthcare costs in India. And so it is basically a big expenditure that, we all are incurring in various forms. If you look at it, doctor visits have increased from 2.7 times in 2017 to nearly 3.2 times in 2018. So basically, our visits to doctors are only increasing. But if you look at insurance, insurance in India traditionally has worked on the cornerstone of more hospitalization as being the key focus area. And I think the key reason for that is that they felt that the hospitalization comes under the hospital category who are more organized as a structure. So they just coordinate with various hospitals rather than when you look at OPD. OPD is a very fragmented structure where basically you have so many providers. So you have a pharmacy, you have a doctor, you have dentists, opticians, etc. And these guys are not as structured or follow processes which hospitals you would see hospitals who cannot follow. Hence, what we've kind of seen when we interact with the insurance companies, they feel it is a challenge for them to work in this environment where these structures are not standardized. However, what we're seeing recently, both at the regulator level and at the government level and at the private level, change has started moving. And a lot of insurers are now looking at adding OPD as a key element into their policies going forward. So consultation fee, pharmacy bills, dentists, optical, all are being now looked at and being put into the policies which are coming up. So if you look at new age insurance companies like HDFC Argo or Max Bupa or Digit or Bajaj Allianz, all have now launched OPD as a element in their solution. And so if you see how they're trying to address it, there are two formats. Some are trying to use it as a technology-based solution, and some are trying to use it as a reimbursement. The people who are trying to use reimbursement are the ones who are challenged in addressing the OPD market because they don't know how to manage it. So they're saying, okay, you first, and then you come back to me and give me those bills, and I'll process it and give it to you. So, however, if you look at Care Insurance, which was Religare before, they rebranded themselves as Care, is using a POS technology. So basically like a credit card machine. So they're giving out their membership cards to people and they're using that to swipe to give them access to PD care. So a lot of people have now started using technology because technology is the only leveler for anybody to look at OPD. Like I said earlier, there must be maybe 50 or 60,000 hospitals, but OPD centers must be like 5x or 6x of those numbers all over India, right? So for somebody to manage that kind of volume of providers where bills are coming in, it's a daunting task if technology is not a key player in that whole thing. And if you look at new age tech insurance companies like Aditya Birla or even HDFC Ergo, they are using now wellness devices as a means to promote a more health living lifestyle, and they are trying to reward their customers by lowering the premium the next year or giving them incentives in buying things which are health conscious. So we are seeing a shift that is happening towards OPD, but given that it's still something that everybody is trying to understand, it will take some time for it to mature as a business in the Indian context. If you look at it in the global context, OPD has in various countries is going through various phases. Either it is being addressed or it is being abused. Where it is being rampant, it's being abused. So basically, people are putting, perfumes under. They're going to the pharmacy and buying perfumes and putting that under OPD. So there is a lot of abuse that's happening. But in some places, it's being neglected. So the jury is still out. How best to address this animal called OPD because it is an important animal to address. And technology, I believe, is the only key cornerstone in delivering it because there is a lot of work towards standardizing happening even at the India government level at various states where we're trying to work with even the regulator to provide standardization. Only if standardization and technology is adopted, I think OPD can be successfully rolled out successfully. Otherwise, we will see OPD being a small element and the insurers not talking about it because they don't want people to use it or they don't know how to address it because it's a market need. They've written it fine in the fine print, but you'll never get to read it. Like, so nobody ever knows, but all our policies have a small OPD element, but nobody knows that it's there because the insurers are grappling in how to address it. So people are now trying to see how to bring it from a fine print to a big print. And I think technology or new innovations is what is driving them to bring that with confidence. Otherwise, people are still thinking twice on how to work or move this forward.
Gagan, I had another question in this. See, if you look at cancer care insurance, the peak of cancer generally is in the 60s or the 50s. But when early bird cancer entries, you don't have those policies. So in India, and when you look at the policy levels, it is as low as 50,000 to 1 lakh to 2 lakhs to 6 lakhs. And there are larger policies which are being very less consumed. So on an average basis, the cost of cancer care, currently you can round it off somewhere around 10 lakhs to 15 lakhs with modern day technology, medicines. Of course, it will come down. But we are looking at a curative intent, not a palliative intent. So do we have such kind of policies quickly, because we are running short of time and we will have to take another question also we have now. Could you actually comment on that?
So I mean, yeah, fair enough. So like I said earlier, I mean, problem that we're facing from an Indian context is the average sum insured for corporate India is sitting at 3.5 lakhs.
Yes.
The average for individuals in India is sitting at between 1 to 2 lakhs. So you are sitting in a challenge where people are not thinking about insurance because they're saying that, health insurances, you pay for the year. If you don't get anything, then, I mean, it's a loss, it's money spent, right? But the human psyche is that, if I don't get anything now in return, why should I keep on spending? Or I keep health insurance as low as possible so that I don't have to pay too much premium. So that psyche is being, is one of the key stumbling blocks in this whole process. But innovation is also a key cornerstone. I mean, like I said earlier, the regulator IRDA has been working very aggressively in a lot of innovations. Earlier, they were very restrictive. There would be only 10 or 12 policy types, and everybody sells across India that 10 or 12 policy types. When you go internationally, the policy types could be a zillion types because the regulators there have given them flexibility to build products. There could be cancer products, standalone cancer products, or there could be a standalone, any product could be standalone. Here, we have not seen it. We are seeing it now. So I would, it is going to start coming up. A lot of people have applied for licenses for standalone products, which are not only health. It could be so I've seen products where dentistry is becoming a product. So you're going to see a lot of products coming up in the future. Regulators are working very aggressive to build a lot of innovation. So you will see
your
that coming
recommendation
forward.
is like working with providers to have more products which covers all aspects. So the population has a choice to pick and choose.
Absolutely. Yeah.
So that is something
Right.
that we have a takeaway from. You rightly pointed out. Now coming on to the COVID-19 pandemic, we have all been forced to get into webinars like this. We don't have options to travel, and this rightly said, telemedicine has come out in a very big way. Now, but there are lots of challenges in telemedicine. And what are these challenges nationally and internationally? And what are the roadblocks that we are facing to deliver telemedicine? I know a lot of it had been covered by Dr. Atul's talk much earlier, but I would like to, call Dr. Uma Anambia to, give your views on that. She has been directly involved with Digital India platforms. So, Dr. Uma.
Yeah, thank you, Ajit. This is a subject very close to my heart because I feel I'm taking a cue from also what Gagan just said. It is the digital technology that is going to reduce the corruption and malpractice and allow us to build ethical systems which will make it easy for even the financial institutions to create better insurance products. So we are looking at driving transparency and ethics in practice. Having said that, yes, telemedicine has been in India for over 20 years. But it is only in the last 5 months that a lot of doctors have heard of it and also thought that it is possible to practice. When it comes to a question of survival, you are willing to explore what you have been always afraid of. And that is the case that has happened with many patients and with doctors. So the trust factor that they had of digital technology, the fear that they had of losing their practice and their patients to somebody else, that has suddenly gone away. Now, is it going to remain like this post-COVID? I think although there would be a dip in the use of telemedicine, but it will still remain and it is only going to get better. Because now we all have tasted blood. But what made this happen? So number one is that when COVID happened, government also suddenly realized that they need to, they announced lockdown and there was like, really, how do doctors reach the hospital? How do the patients reach the hospital? So on 25th March 2020, the government facilitated telemedicine by announcing the telemedicine practice guidelines, which will allow a doctor to do teleconsultation legally and charge for it. Now that made it easy because you need to be paid for your work. But today, do all the doctors know how to indemnify themselves against what are the problems that can face in telemedicine? They don't. So we have not done enough training of patients and of doctors, which is really required because there's just few things. Have we put in place the way how we will validate that it's not a quack and it's a really a doctor at the other end? Can we validate it through the registries? We don't have a registry. Our state registries do not talk to each other. So many of the telemedicine solution providers do not know how to validate that it's a doctor. We need to have solutions that validate the patient's identity. We don't have that. How do you know that it's not a crank call? Somebody trying to harass a doctor. So we haven't got that in place, but that needs to be. So there are many solution providers that are putting that. Do the doctors know which telemedicine solution to select from the hundreds of vendors that come knocking at his door saying this is the solution that you must use? COVID has seen the emergence of many fly-by-night telemedicine operators. Okay, not all of them are going to stay. So we, in fact, got approached by CAHO, and Digital Health India has made a telemedicine registry, which we will be publishing maybe next week or the week after next, so that the users know where to go for when they on their defined needs, which solution to take. This is required. But has the government put in place adequate measures to look at security of the data of the patients? Whose responsibility is it? Is it the responsibility of the hospital, the doctor, or the telemedicine solution provider, or the government? We still do not have an answer on this. At this moment, it is supposed that the doctor or the healthcare provider will keep the data safe. Good heavens, how? Do the doctors have the knowledge on what is the data security in IT? Do we know the bills? Do we know what it implies? We don't. But it is assumed that the doctor has to keep that data safe. Doctor has to keep the record of that transaction between the patient and the doctor for undefined number of years. It doesn't say how many years you need to keep the record. Which record? Your text, your chat, your WhatsApp call, or is it your audio video call on a telemedicine platform? It is very unclear on all that. So we need to resolve all this. It is good to have the telemedicine practice guidelines. It's a great move by the doctor, but until and unless you have a patient data privacy bill that comes up, there is health data protection policy that comes up, you understand that telemedicine or the teleconsultation in the digital health world is going to be the most basic unit. It is the equivalent of a primary healthcare center on a brick and mortar structure. Telemedicine is going to reach you to the patient's house. It has to start from there. When on 15th of August, Prime Minister announced NDHM, Digital Health India movement, what he didn't say was that if NDHM has to happen, teleconsultation has to happen for every citizen. Every healthcare provider must know how to do it. We must put it in the medical curriculum. So this is the requirement. They are saying we will have patient's health record. Now you can't have a PHR if the patient cannot consult a doctor on his phone. We are talking of giving a PHR in NDHM. So this is a reality that we need to see. But is it something that is going to happen? Yes, there are excellent telemedicine solutions that have been developed, and they have fast forwarded their development. They're really fast tracked, and they're trying to meet up to all these requirements, meet these criteria. But what is keeping us from teleconsultation across countries? Because the telemedicine practice guidelines in India cover us for practicing within the country. So there is a catch there. Physically, I cannot practice in Tamil Nadu or Bangalore or Sindh without the state medical registration. But on teleconsultation, I can consult across the country. But there is a conflict here which needs to be resolved. We need to have a unified registry in the country, number one. That's when we can think of a digital health in India. We need to have a digital directory of every service provider, which is unified across the country. So that is required. But now across countries, why we cannot have it? Because every single country has its own data protection law. And you need to match with the data protection laws of the other country. Will that country allow their patients' data to be stored in a server outside? Will they allow traffic of that data across borders for the patient-doctor transaction? Those things need to be resolved. There are huge questions. It is not easy. It requires the Ministry of Health, the Ministry of IT, and the Ministry of Telecommunication to work together to come up with the standards that are required. But it is a good thing that we at least have something that we have tasted now. We know it is working well. We need to, of course, educate ourselves, and we need to educate the patient community and the doctor community and how to use it, how to feel safe about it, and how to use it to the best of their ability, and educate the doctor and the entire healthcare provider community to choose the best solution, which is going to stay. So this is my small view on telemedicine.
That's a very comprehensive view, and you have actually elaborated that on a click of a phone, it is not so easy because we have to be regulated and we have to be very stringent with these norms to elicit this into this thing. But there was another question which I'll actually go through myself, which was like building data repositories in the state, so that in Kerala we have a lot of wealth of data, not only and patience and expertise, and the possibilities are endless. Where we can build registries, education levels are high, people themselves will be willing, and if we have a common registry between hospitals and government together, lot is easy. Like in organ transplants to direct processing, analytics, infectious control diseases, and multiple others. That was one of those questions, but that we had to discuss. And due to lack of time, that needs to be much collaboration between hospitals and doctors, as well as private hospital sector with the public sector to create. Then the format of it again is Digital India. So the data privacy also comes into it. The backbone would be that. And not only in Kerala, if we can put it across India, maybe that could add on to make things easier. Means the listed drug producers, what drugs are safe, which companies are not, which are the ones that are debarred. Like FDA has those norms over which can be sold and which cannot be sold. Many drugs can be camouflaged under the cosmetics brands and are coming into the market. So be it in modern medicine, be it in Ayurveda, be it in any field, there has to be a recordical evidence that this is safe, and that is a structure base. It has got nothing to do with anything else. Record it, and the data will be really useful. So with that, I would like to come to the last question, which again I would like to put it to all panelists, whoever may discuss. This is a thought that we have discussed about inward medical tourism. There remains this great void of a popular, proper regulatory forum, as in a ethics committee, or a data repository and an ethics committee, a sample biorepository, or any of those kinds where we are all talented. We provide the world with the best of doctors. We provide the world with the best of nurses. There is so much of talent and there is so much of outflow. Why is there so much of outflow from Kerala and nobody wants to come back here when they are already set up? Because they get all these benefits abroad. So bringing back talent and stopping talent drainage from our state is what will eventually lead to inward medical tourism, and bringing the knowledge that these people have to take outside, like in establishing a clinical database, a clinical ethics committee where anybody who has some a good research material to be tried out, it has to go through a format of ethics committee. But currently it is hospital based. Now when you want to do multicentric trials, or not trials alone, coordinated work between hospitals, you have a lot of roadblocks. And when it comes to government institutions, doctors are scared. Just like in organ transplants, when rumors come out that you're killing people for organs, kind of situation, you're experimenting on humans based on unproven technology. These kind of talk can be prevented to a great extent if we have a common forum which can be addressed across the state to start off with, probably across the country, where even this helps Ayurveda, this helps the other faculties to integrate the research on a platform. It need not be for just modern medicine alone. It can be for other faculties. Let's work on our strength. Your thoughts? Any other panelists can start with this, on this thought.
So let me start with this. So I feel very strongly that it is not just about bringing back talent that has gone from here. It's about trying to collaborate with research facilities which are outside our country. There are excellent research facilities which some of us do not have access to. But we, with a 1.3 billion of population, are the ideal center for phase 3 and phase 4 trials. Okay, we also have a lot of material, clinical material, which is required for research. So why should we not create collaborative platforms? And Ajit, what you said about, having an ethical committee, the ethics committee, we need to prove that we are not corrupt by nature. We need to prove that we are not swindling people. We need to prove that, we can do quality clinical work and that we have the honesty and transparency required for research. We do not have that reputation. So how is it, can we make our state or our state bodies or leaders the poster boys of ethics and transparency in clinical research? We need to actually have a movement to do that. And we should think and collaborate with institutions in the West, excellent institutions that provide the research facility. We have doctors who've gone from here, who are working in those places, who are doing research projects. We could ask them to bring their research products here. We can have the clinical material from here, analytics done somewhere else, and published jointly, ethics actually coordinated and collaborated jointly, supervised jointly. That is the way we need to work. And now, as we've just said, that with so much of digital technology available at our fingertips, it doesn't matter where you work in the world. The world is as big as your phone, actually. It is consolidated inside your phone. So we don't have to travel anywhere to do all this. So I think that is what I would, have to say about trying
I'd
to
like to bring Rajiv on to his thoughts on this. So, yeah. Rajiv.
Just a minute. I think the trees per se. Back, Dr. Kumar has already touched upon it. I think the entire issue of patient data, right, privileging privacy rules, has to be completely clarified. Although there is a Data Protection Act and on the anvil, there is something already proclaimed. There's NDHM which is coming, which is going to bring in greater teeth to the whole the area. But I'm going to get back to that earlier topic of integrated medicine and building evidence for that, because I believe there will be a few like-minded people who can get together in Kerala, take 2 or 3 pilot programs, take out of the many diseases I spoke about, take 1 or 2 or 3 and actually do collaborative research and establish a working model, right, for 1 or 2 of those conditions. World-class evidence, get the world to come to Kerala for that, and then expand the range of this thing. So I'm going to go to a very focused thing of health tourism, attracting the world to Kerala as a healthcare destination. But you need like-minded 2 institutions to come together and really work on it with an open mind. That's the larger part I want to see, kind of twinning to happen. And on the one small point, going back to what Gagan spoke about on insurance, I just want to expand that very important point. Again, from the market building standpoint, there are both, yesterday we were talking about it. There is West Asia, some countries, universal health coverage. You have in the East African countries, other countries with universal health coverage. Now, why would they come to India for medical care under that insurance? There are TPAs which are covering care in India, cashless. For Ayurveda and allopathy together, people will travel from those geographies to come to us for medicine. So I want to say insurance is a great trump card for Kerala. If we leverage it, go and empanel hospitals for that integrated model. So these are some final thoughts at this point.
Thank you, Gagan. With this, we come to the end of our session. I would, ask Abdullah or any of the other panelists to, if they have any more comments to bring on board.
I think Joe's done complete.
Dominic, sir.
Yeah, I just want to add to what Rajiv has been saying. See, Kerala has got a great reputation as a tourism destination. Thanks to, the definition of responsible tourism is a great place to live in, is a great place to visit. In that, Kerala has achieved the Kerala model of high HDI has achieved that model. 2, in Ayurveda, we have got global reputation of global excellence. 3, now you've got modern medicine. Now, Rajiv's model of integrating modern medicine and Ayurveda is a challenge. And while that could be attempted, I would say that we pursue our direction of Ayurveda, where we've already achieved, and get it across to the world. Get it, both to see, the problem with Ayurveda is most people in Kerala do not go towards it. Youngsters, or what we call the modern yuppie, does not touch Ayurveda. So therefore, many people who come here and will come and ask, what about you? Do you seek Ayurveda solutions? Very often we say no. Is it only a foreigner's solution? That apart, and I think this integration is a big challenge, and that will create a new model for Kerala. But even before you achieve that, let's pursue putting Kerala as the Ayurveda capital of the world. Already it is there. We have big challenges. We have got other challenges in other states. But our big advantage is the Kerala model of society and economy, and the Kerala model of tourism to help us brand it, pack, and having unique identification. And that is what is a big strength. The next challenge or the next forward step will be post-COVID. COVID has brought about big changes. COVID has brought about new protocols. Post-COVID, and then you will come into what has been just discussed about telemedicine. And I know for a fact that where in our establishments, when we have a patient inquiry, the discussion begins with before he comes here from whichever country he is, discussion with the physician. He comes here, and after he goes back, he has unlimited time for follow-up with the physician. So now in telemedicine, without coming here, how can that be achieved? So with post-COVID, we have a new what is called a new normal, and there too we can probably have a solution in this way. Yeah, I'll stop.
We do have some questions from the audiences, so we would like to take those questions as the last moments. Dibu, can we take those questions? Do we have enough time to continue?
Yes, probably we'll take 1 or 2 questions. A few questions which came across, I have shared it in the chat for you.
Okay. So one of the questions which came is, being a frequent visitor to Kerala from Oman for treatment, I found it hard to communicate to hospitals as there is a lack of translators considered this as a suggestion to engage certified translators so that we feel very comfortable. I would, would Ms. Abdullah or
we have already,
please take this.
we have already covered that subject in my discussion. And of course, in most of the hospitals, including Lakeshore, we have got the translators. That's what I told that. I mean, we have to educate the facilitators themselves so that the patients will be more comfortable. If there is a format, I mean, if there is a structured system, then the problem of the language also can be covered. And we will be happy to have more and more translators. So that there are more and more people who are coming from Middle East, who are fluent in Arabic language. So we can employ them so that can be also be any instrument for the marketing also.
So can we have the next question, Dipu?
So the next question is basically, can we promote Kerala as a whole with scenery, modern medicine and Ayurveda and not marketing separately and fighting each other?
I think, that question was well answered by
Yes.
Rajiv himself. And obviously, yes. And Jose Dominic sir also has actually brought in his views on it. Definitely, there is room, there is tremendous scope in marketing Ayurveda and, modern medicine together, because these are the strengths and identities of Kerala. Ayurveda was there much before modern medicine ever came to Kerala. So, we should be in a situation to do that.
So just one supplementary comment, Dr. Ajay. Beyond the scenery and the modern medicine, Ayurveda, I think there is a hard marketing of the benefits of the type of diseases which can be treated, or the kind of outcomes we can offer only through the Ayurveda and the modern medicine together in Kerala. So I just want to say the scenery and other things are not going to, that's the old kind of medical tourism. The actual hard medical tourism is people coming for medical value travel. So I think we need to go on that benefit part a little bit stronger in our communication.
So coming on to something that was passed on to me on my WhatsApp, this was a very critical question, and I was thinking whether to put it on. The question was, in a world where every hospital is competing with each other, how can you collaborate? That was a very difficult question. So, frankly, it isn't a difficult question. Probably it is for the person who asked the question that it was difficult. Frankly, a hospital itself is a place where we collaborate. Each department itself collaborates with each other. And when you look at it, I'm from the field of diagnostics, so we collaborate with multiple hospitals. I'm also from the field of imaging. We collaborate. Hospitals collaborate with each other. Knowledge sharing happens. And this is a platform where we can work together and we can work wonders. If you look at the Western world, every hospital doesn't do everything. There are specialized segments, and the structured basis of referral in NHS also comes to that kind of an approach. So resources are, very resourcefully used, and we channelize most of it. But we are in that direction eventually, and we have a huge population with a different, varied economic strata. That is what I have to comment on this. We are already in this space, so rest of the panelists can, contribute to answering these questions on your views.
Yeah, generally people somehow tend to think, the way people think is that a competition means conflict. Actually, that is not true. Competition and conflict are two very different things. And here what we are talking about is that we can compete with each other, yet we can collaborate. Yes. And that is the key. And we all know when to collaborate, what are our core areas, what are our non-core areas. If I do not have a good lab, or if I don't have a good pathologist, it would be foolish not to collaborate with a diagnostic chain, right? But to provide the best to my patients. And that is the kind of collaboration that we need to talk. And what we have been talking for the last 1.5 hours, and if I were to just, say what my takeaway from here is that we need to make a niche by collaborating with Ayurvedic and allopathic systems of medicine, and requires a very scientific approach, like what Rajiv has said. Define, objectify what we are doing, document everything, create evidences for what we are trying to claim, do research on it, and do evidence-based practice of this integrative model. And that is a collaboration that I would think that we should, leave aside everything else, understand, internalize that there is no conflict between two systems of medicine, and to a large part they complement each other. And that is what we are talking about, treating the patient rather than treating the disease. So you need to treat a person as a whole and not just look at disease and body parts separately. And that's my learning from today's seminar. And thank everybody for driving that into me. I'm happy that I was part of this session.
Thank you very much. I would like to thank each and every panelist, starting from Jose Dominic sir, SK Abdullah, Dr. Uma, Rajiv, Gagan, and most of all, CII to be organizing such such a session. I know this the topics that we covered doesn't cover everything, and each sentence that was spoken or each sub sentence that was uttered could be a seminar by itself. But I believe within this time frame of 1.5 hours plus, we could do justice to the most important and salient points, and how and we think we have put a start to a long process where CII and multiple other forums could collaborate and take it forward to the government and make it happen, rather than we talk about many things, but many a time it doesn't go forward. So once again, thank you very much for your participation, and to all who have been listening, thank you very much to all the panelists once again.
Thank you, Mr. Ajit, Dr. Ajit. We have to congratulate you on behalf of the panelists to contain 10 sessions in one session. 10 subjects which we have covered, it is enough for 10 subjects, 10 sessions. So we have to congratulate you, and we have to thank Mr. CII. And I asked Deepu to consolidate this one in a paper and submit to the government also. Thank you very much.
Thank you all. Thank you.
Thank you. Just to update you all, we have 472. That was the peak viewers we had during our session, just to update you. So all the sessions are recorded and is on live also. I'll be sharing you all the details shortly. Thank you once again, the moderator, Dr. Ajit, Abdullah Sir, Uma, Gagan, Past Chairman, Josh Dominic, and Rajiv Vastavan for all your support and help. Thank you so much once again. Have a great day. Thank you.
Thank you.
Thank you. Thank you. Thank you. Good night.
Thanks. Good night.